Okay, we will start now.
It has recorded. It has started recording. Yeah.
Sir, should I start?
Yes, yes.
Yeah. So, with the due permission from the organizer, our President Rekha Jha ma'am, Kavita Varnawal ma'am, and Chairperson Neeraj Jadhav sir, and all the chief guests, let me start. So, good evening to all of you. Welcome in this exciting session of the Sexual Medicine Committee with the Bhagalpur Society and all the other society of Bihar and Jharkhand. I, on the behalf of Sexual Medicine Committee, welcome you all. So, I would like to invite our I would like to invite our own president of Bhagalpur Society, Dr. Rekha Jha ma'am, to give the insight of all this program. What about all this webinar? Because Rekha ma'am and Kavita ma'am is the active since and doing the webinars and academic session regular basis. So I would like to invite Rekha ma'am to have her words and to start this program. Over to you, Rekha ma'am.
Thank you, Apurva. Thank you very much. Today is the 21st February, the month of February and 21st. And with the Sexual Committee FOGSI, we have planned this webinar, and the topics are really intriguing. I welcome all the members who have joined. Especially, I would like to welcome Dr. Asha Bakshi Madam, who is the Vice President in charge of the Sexual Medicine Committee, and Dr. Alka Pandey Madam, who is the Vice President of the East Zone and of our zone. And I would like to welcome Neeraj Jadhav, who is the Chairperson of the Sexual Committee Medicine FOGSI. So, and all the dignitaries, all the senior members who are with us today, it is a very happy moment for us because it was in my mind to have this webinar with the Sexual Committee, because actually much of the things we don't understand and we really don't talk about it. And today's webinar will enrich us on those things which are usually not spoken by the patients too, and which is not really treated as a disease. It is a psychophysical disease, and these things will be spoken of in by the various speakers today. And it is a very, very good thing that we are having so many people joining us today from all over Bihar, and also from Jharkhand, and our own senior members as guest of honors like Dr. Pratibha Rai Madam, Dr. Kumudni Jha Madam, Dr. Suman Sinha, and Dr. Anju Singh. They are all senior people from Bihar and representing various societies in various capacities. They are active members. They have been doing things, and we would like to honor them today in this webinar of ours together with the, which is actually a webinar of Sexual Medicine Committee FOGSI together with our Bhagalpur Society. And we have involved everybody from Bhagalpur, from Bihar and Jharkhand. And with these few words, I would like to hand over to Apurva to continue this today's program. Thank you.
Thank you so much, Rekha ma'am. You being we attended few as by the AI. हम लोग का जो अपना AOG BGS का conference था by you, by Kavita ma'am, by Roma ma'am. It's a wonderful, and you are so academically. Thank you for giving us this platform. So I would like to invite my co-moderator, very senior Dr. Madan sir, to welcome our chairperson Neeraj Jadhav sir.
Thank you, Dr. Apurva. On behalf of FOGSI Sexual Medicine Committee, I once again welcome you all. And I'm very thankful to Dr. Neeraj sir, who is very dynamic chairperson, I think, from the FOGSI. He is doing a wonderful job. And currently he is a chairperson and he is past president of Rajkot Obgyn Society. And I congratulate sir for arranging this wonderful webinar with Bihar societies. And I request sir to say a few words. Over to you, sir.
Thank you, Mother. So, welcome to the Sexual Medicine Committee webinar on sexual.
Neeraj sir, sir, sorry to interrupt. There is some problem with your video.
Yes, I know.
Can you just?
No, it's.
Sir, तो आप इसको. Okay.
It's not working, so don't worry. It's okay, no problem. So welcome to today's webinar by the Sexual Medicine Committee on sexual health, jointly organized by the Bhagalpur Obgyn Society as well as other societies of Bihar and Jharkhand. So I'm thankful to Dr. Rekha Madam and Dr. Kavita who started this process of organizing this webinar, because without their help, this webinar would have not been possible. So when Dr. Rekha Madam asked me, can we do this on 21st February? So I was a little bit worried, because in our webinar, we usually have a 1 month time to go about any webinar, but she said we can do in this 10 days. So I'm happy that we are able to do everything within short period of time, and we are today live on this webinar. In Sexual Medicine Committee, we are trying to reach all Foxians to spread the awareness and the knowledge about the sexual health. Sexual dysfunctions are not uncommon. Roughly 30 to 40% prevalence rate of sexual dysfunction. So every second or third person you are meeting have some sort of sexual dysfunction they have faced in their lifetime. So why we don't come across patient with sexual dysfunction if there is so much high prevalence? There are so many factors. There are socio-cultural taboo associated with the word sex when there is any sexual problem. Patients are suffering silently as they feel embarrassed to talk about their sexual issue. Sometimes they rely on quack, they rely on their friends and qualified persons to seek help. So as a doctor, this subject was not taught in our curriculum. We have a full OPD where we don't get enough time to get proper sexual history, which is very important. And sometimes we might feel that this is not our domain. So no sexual medicine, no, but sexual medicine is a very much part of gynec practice. So overall scenario is quite bad as far as the sexual health is concerned in our country. So Sexual Medicine Committee is trying hard to change this scenario, because as gynec, we have a very good rapport with our female patient, and if we ask them that they will open up about their sexual problem, and then we can solve their problem. And believe me, you don't have to be sexologist to manage your patient with the sexual problem. We do so many basic practice, like we do sonography practice, we do oncology practice, we do menopausal practice, we do infertility practice. We are not IVF specialist, we are not fetal medicine specialist, but we do all basic practice. Same way we can do basic sexual medicine practice also. Once you start, then whole new universe will open to you, and sexual health is important for our health too. So we can't neglect this if we as a Foxian want to improve the sexual overall health of our country. So welcome once again to all the viewers and all the faculties, chief guest, and our guest of honor who has joined for this webinar.
Sir, you have muted. Please, Neeraj sir, please unmute yourself.
I think I have some problem in my laptop. So welcome to everyone and have a happy learning. Over to you, Apurva.
Thank you. Thank you so much, sir. Sir is the main force who is behind all this program. So thank you so much, sir, for bringing with this initiative. So my dear friends, as we know, in our culture, we started any good thing, any auspicious thing with the blessings from seniors. So we have a very, very special guest as a guest of honor and chief guest for us. I would like to invite the very dear Dr. Asha Bakshi ma'am. Ma'am doesn't need any introduction. Ma'am is the Senior Vice President Foxy, West Zone, and ma'am has chaired the AICOG 2022, and it was a wonderful, and she is so helpful, so humble for all of us. So thank you so much, ma'am, for coming us, for blessing us. Over to you, Asha ma'am, for your kind words.
Thank you, Apurva, for the kind introduction. And this month has been the month of Valentine Day, and it seems Neeraj has become too active that every week he is doing a webinar on sexual medicine. So he's really celebrating this in the real way. And it is so nice that Bihar and Jharkhand members are so active and participating with so much enthusiasm. And especially my congratulations to Bhagalpur Society, especially Dr. Jha and Dr. Kavita, who have taken all the pains to conduct this webinar. And so nice to see Dr. Pratibha Rai, Dr. Suman Sinha, Dr. Anju Singh as guest of honor. And I greet Dr. Ruma Shukla, the speakers, Dr. Ruma Shukla, Dr. Padmini Prasad, Dr. Monika Gupta, and Dr. Pratibha Singh. You have been excellent, Apurv and Dr. Kamble. You have been very excellent. All the webinars, you are so engrossed and you look into the nitty-gritty of everything. And as such, I think sexual medicine has always been very neglected, and we have always shied away from it. So very important to increase this awareness, and we all should, in our day-to-day practice, in our clinical sheet, we should have one column where we ask the patient about the sexual problems, and we can initiate if patient doesn't initiate and she's feeling shy, then we can ourselves initiate the sexual history, and then a little bit initiation will open up so many chapters. So very, very important, and happy learning to all of you. Thank you.
And one thing I tend to forget you that one minute.
Thank you so much, ma'am, for always being there, for always your kind words. Next, we have our guest. Yeah.
Apurva, I think Dr. Neeraj wants to say something.
Yes, sir. Yes,
Yeah,
sir.
and one important thing I forget to tell you, everyone, that probably in the month of May, we are coming with the ICOG certificate course in the sexual medicine. So all of you should take advantage of that course and take part in that ICOG certificate course in sexual medicine. We will send the details to every president and the secretary. I request all the president and secretary to pass out this when this date comes. Pass out the information about that course to everyone. Thank you.
Great.
Thank you so much, sir. So next, our chief guest is none other than but very dear senior, a teacher of teacher for all of us, Dr. Alka Pandey, ma'am. Ma'am doesn't need any introduction. Ma'am is again the senior vice president, Foxy East Zone, and one of the most respectable, seniors of Bihar and Jharkhand, and now all over the India. So thank you so much, ma'am, for always your blessings, for always your guidance, for advice. Over to you, ma'am, for your kind words.
Thank you so much, Apurva, for the kind introduction that you have given. And Dr. Neeraj, Dr. Rekha, Apurva, Pratibha, Kavita, Asha ji, and everyone present here. Thank you very much for inviting me. And it is really, we are not much aware about sexual health. Yesterday, a girl came to me. She had been married 4 years ago, and still she is not cohabiting with her husband. And she said, I'm feeling very scared, and I feel very much pain during sexual intercourse. So I was also in a fix what to advise. So we are not aware of what to do because we are not coming across such problems very frequently. So it is really nice to be a part of this webinar so that we can learn. And it is very nice of Dr. Neeraj Yadav to start a certificate course on sexual health by the ICOG. Really, congratulations, Dr. Neeraj. And thank you very much. Go ahead with your this happy learning.
Thank you, madam.
Thank you so much, ma'am, for your kind words, for your blessings. So I would like to hand over to my co-moderator, Madan sir, to invite the guest of honors. Over to you, Madan sir.
Thank you, Dr. Apurva. It is my privilege to welcome today's guest of honor. We are really feeling honored to have Dr. Pratibha Rai ma'am and Dr. Kumudini Jha ma'am, Dr. Suman Sinha ma'am, and Dr. Anju Singh ma'am. I would like to welcome and introduce Dr. Pratibha Rai ma'am, who is currently the president of Dhanbad OBGYN Society, and he is so senior most OBGYN consultant from Dhanbad. And I would like to welcome ma'am, and over to ma'am for your kind words.
Madan sir,
Yes.
Pratibha ma'am is not there. She's being stuck
Dr.
in some
Pratibha Rai
emergency.
couldn't join. Yeah, she told me she could
Yeah,
not join.
yeah.
She's busy
Uh-huh.
somewhere.
Okay.
So,
Okay.
Suman ma'am.
Dr. Suman Sinha, madam, and Dr. Kumudini Jha
Kumudini madam
madam
is
are there.
there.
Kumudini Jha madam.
Okay.
Kumudini
Our
madam
next
is
guest
there.
of honor is Suman Sinha ma'am, who is the senior most consultant from Ranchi. We welcome ma'am, and I would like to welcome ma'am and to have blessings from ma'am. And over to you, ma'am.
Okay, Dr. Pratibha Rai has joined just now. Okay, so next
Okay.
we can take blessings from her also. Next time from after Suman madam.
Yes. Yes, Suman ma'am.
Suman ma'am, I think she is also in some
Okay, Dr.
webinar.
Pratibha Rai.
So we
Yeah,
will,
Dr. Pratibha Rai.
Pratibha Rai ma'am is there. Ma'am, pranam ma'am. Good evening, ma'am.
Why don't you ask Dr. Kumudini Jha to bless us
Yeah,
first? She
yeah.
is there right
Ma'am,
from the
yeah, Kumudni
beginning.
ma'am.
And to tell you, she is the senior most. She is the senior most.
Yeah, definitely, ma'am. Kumudni,
Thank you, sir.
and I just wanted to add one more thing. Kumudni ma'am is almost every time in 80% time in our webinars.
Yes.
I always see that
She is
so
always with
active and
also with our webinars.
She is very
and
madam,
after
active
the
and very
webinar, she
senior.
personally
so
messaged me,
academically
well done,
strong.
Apur, you are
She
doing
loves
great. So thank
reading
you so
and
much,
teaching.
ma'am.
Yeah, Kumudini madam always loves reading and teaching, and she is always active in academic activities.
Thank you so much.
Kumudni
for
ma'am,
this
over to you, ma'am.
Thank
Yeah.
you so much, Purva, Rekha, and now Dr. Kavita. I am really honored by your and floored by your kind words. And I must say that you have such a platform on which there are specialists, experts in this field like Dr. Apurva, Dr. Neeraj Yadav, Dr. Kamal and all, and Dr. Madan. They have done extensive research on this topic. And it is so important that you have had 4 guests of honor on this. So it is a topic which is not often discussed, and millions suffer quietly, and and they even end up in broken homes just because of this problem, and they don't seek help because of this personal issue. And when they do look up to us for help, our ignorance of this subject precludes us from showing them the way out. So to build awareness amongst the gynecologists on this topic, this CME has been executed by the Bhagalpur Obgyn Society today. And counseling is a very important aspect of this issue. That means you speak to the distressed couple, but before speaking, we have to be very intent listeners so that we know we focus on the problem, and we know exactly what the actual problem is and where lies the solution. So the causes could be as simple as ignorance of consummation of marriage, as Dr. Alka Pandey has just said. There could be a poor rapport between the two of them, or there may be a lack of respect or trust, and they may be from conservative family backgrounds, so it has never been discussed. And they may now, in this era when both the partners are working, there you have they are overworked all the time, they are irritable, and as a result of tight work schedules and their work pressure, so most of the time they have, and some of them may have unpleasant experiences in the past, or some may have had a sexual abuse in childhood. But we must know the differential diagnosis also. It's not that it is always when the patient comes with a history of vaginismus, or there is vulvodynia, or there's chronic pelvic pain. These symptoms can be the interstitial cystitis of the bladder pain. That can masquerade as these symptoms. So we must know that what is the differential diagnosis, and in the urologists, they try to exclude these before diagnosing the bladder pain syndrome. The couple may need help, and we may need help from the aesthetic gynecologist friends.
because some of them may have pain because of the fibromyalgia in the levator muscles, and the arousal may be lacking. So they may be treated at the G point injection at the G point in the posterior vaginal wall by aesthetic frames. So we have a lot of learned speakers, and I don't want to come in between the speakers and the delegates. So thank you so much again, Dr. Rekha, Kavita, and the whole Bhagalpur Society. And I'm really eager to listen to this webinar. Thank you so much.
Madan?
Thank you so much, ma'am, for your kind words, your blessings. And Neeraj sir, we always enter the, who are the attendant, and 80% of our webinar, Pudhini ma'am is there. So thank you
Thank
so
you
much,
so
ma'am,
much.
for all. And even we can't, match your level of energy which you have. So really, age is just a number for you.
Thank you so much. But it is really inspiring to hear you people and discuss such new topics, and which have not, we also haven't studied in our curriculum. Thank you, Apurva, and thank you, Dr. Neeraj.
Thank you so much, ma'am. We have Pratibha Rai ma'am with us. Ma'am, Pratibha ma'am. Ma'am, you have to unmute yourself. I think she's not there. Okay. We
Dr.
have
Suman madam is there.
senior
Suman madam.
Okay,
so
yeah, Suman ma'am, very own. She's like senior, she's guide, she's like a great for me personally. Ma'am, very friendly, and thank you so much, ma'am. Ma'am doesn't need an introduction. At present, she is the president of Ranchi Obgyn Society. Over to you, ma'am, for your kind words and your blessings.
Thank you, Apurva, for the kind words. And can you hear me?
Yes, yes, ma'am.
Yes,
Okay.
yes, ma'am.
So, good evening and namaskar to one and all.
Yes.
It's really a very delightful opportunity for this. I'm extremely indebted to the luminary and dynamic chairperson, Sexual Medicine Committee, FOXY, Dr. Neeraj Yadav sir, and my friend, President Bhagalpur Society, Dr. Rekha Jha, along with a very vibrant team. I myself feel so privileged to be a part of this webinar and also to share the dais with the dignitaries like Alka madam, Dr. Asa Bakchi madam, Dr. Kumudi Jha madam, and so many glitteries are here. And regarding this webinar on the sexual health, it's really a very untouched subject, very less discussed. And so we are going to have the opportunity to know the nuances of sexual medicine, and different subjects have been touched, like vaginismus, then FODs, FSAID, and about the sexuality in pregnancy. So in my opinion, I think that apart from us only gaining this knowledge, these awareness programs should go ahead to the communities, to our care takers, because we give awareness programs in our caregivers about how to prevent cancer, how to prevent anemia. We should also tell them about this, and that will improve their quality of life. So without taking much time, I really congratulate all the organizers for thinking of such a important and very, very different topic for discussion today. So my best wishes for the success of this webinar. Thank you very much.
Thank you. Thank you.
Over to you.
Thank you so much. Thank you so much, Suman ma'am, for your kind words. And मुझे तो लगता है कि मैं राज्य सोसाइटी का ही हूँ. It is so much connected. Thank you so much, ma'am. Pratibha ma'am, Pratibha Rai ma'am. Yes.
Am I audible? Am I audible?
Good evening, ma'am. Yes, ma'am. Ma'am. For Pratibha ma'am
You
is
are
like
not of
mother for
Ranchi
us.
Society. You are not of Ranchi Society. You are of Dhanbad Society.
Bilkul, ma'am. Bilkul.
My best wishes and best of luck. Good evening. Good evening. My best wishes, and it is a very nice media to know about sexual problem. which we are, most of the time we are not discussing with patient or in any webinar. So Apurva, you are doing very excellent job, and my best wishes to whole team. Thank you.
Thank you.
Thank you so much, ma'am. Ma'am, आपका mere presence और your blessings बहुत है ना? You are in your busy schedule. You give us the time that is all we needed. Thank you so much.
Apurva.
Thank you. So I would thank you. I think Anju ma'am is not there. Anju ma'am.
No, she couldn't join, so leave her.
She's going
We can
okay,
proceed.
okay. Yeah, thank you so much, ma'am. I would like to hand over to Madan sir to start our first session. Madan Kamble sir.
Thank you. After getting the blessings from the stalwarts and the senior-most, our chief guest and guest of honor, we will move on to the scientific session. Our first session speaker is Dr. Uma Shukla ma'am, and the chairpersons for the session 1 are Dr. Nivedita Datta ma'am, Dr. Poonam Sahai ma'am, and Dr. Lata Shukla ma'am. I welcome all the chairpersons who are the senior most OBGYN consultants from Bihar, all the societies of Bihar. I request Dr. Nivedita ma'am to introduce Dr. Uma Shukla ma'am. Over to you, Nivedita ma'am.
Dr. Nivedita, is she there?
Not here. I think she had joined. She told me, but I don't know.
Is
Let
it
me
Dr.
ask.
Poonam ma'am? Poonam ma'am or Lata ma'am?
Nobody there. Okay. Okay.
No need of
the CV.
introduction. Yes.
So it is okay. We all are chairing the
CV.
session,
Yeah,
Dr. Ruma.
Yeah.
So you
Yeah, no,
can proceed
yes.
with your talk. If your
CV of,
chairperson will
yeah.
join, they will
Apurva,
give
you
the
can
post
introduce,
comments.
madam.
Okay.
Please share the CV of Dr. Ruma Shukla. I will introduce her.
Yes, this is my CD only. Just a consultant, gynecologist, and infertility
No,
specialist. That's all.
let me speak a few words. So please share the CV of Dr. Ruma Shukla.
Ruma madam is the past president of the Indore Society, and she is the Western coordinator for the Sexual Medicine Committee.
Okay.
Thank you so much. Am I audible?
Yes, yes, ma'am.
Yes.
And visible also? Yeah. Thank you,
Yes.
Bhagalpur Society, Dr. Jha, and the other Bihar societies who have organized this webinar, and Dr. Neeraj Jadhav, Chairperson Committee, Dr. Apurva, Dr. Madan, they all are working so hard to make the gynecologists aware about the sexual problems in nationwide, from east, west, north zone to south, everywhere. Thank you so much. When we see our Indian history, our ancestors were very open, and they were, that time, the sex and sexuality were depicted in our scriptures. Temples like Khajuraho, Mallikarjun, they all show sculptures on these things. They take it as a journey towards spirituality also. But after the invasion of India with Mughals, then Portuguese, then East India Company around 14th centuries, the rich culture of India was wiped out. Still, in modern society, we don't talk about the sex. A husband-wife, they don't talk about the sex. That is the main problem. The big taboo is still present in our society. Even in some families, they take it talking about sex as a sin. So now we have to aware. When I was doing my infertility practice, I saw that the many couples are suffering from this problem. And I myself, they don't know, because it was not in our medical curriculum taught about the sexual medicine. So we have to be aware about this, and I must congratulate Neeraj, Apurva, and Madan for making so hard efforts for this. Now, today I'm going to talk about female sexual interest and arousal disorder. The women are considered as
Have you shared your screen, because we are not able to see?
Am I not visible?
You are visible, but screen, you have shared your presentation?
Yes, I have.
We are not able to see your presentation.
Okay.
Just a minute. Is it now?
No.
No, ma'am.
Oh, just a minute. Oh, sorry. Just a minute. But I am audible, is it?
Listen, we are not able to see. Now it has started.
Now it is.
Wait. Yeah. Make it full screen.
Is it visible now?
Yeah, perfect.
Yeah.
Perfect.
So how we define female sexual interest and arousal disorder? Whenever there is deficiency or absence of fantasies, desire for sexual activity, and which is leading to marked distress or interpersonal difficulty amongst the couple, then it is termed as female sexual interest arousal disorder. DSM-5 has described it has given few symptoms. They are whenever a couple is having no or little interest, or few sexual thoughts, or few attempts, or pleasure or excitement, or interest in internal or external erotic stimuli, or no or few genital or non-genital sensations in 75 to 100% of cases. When out of these, at least 3 symptoms are present for 6 months minimum, and which are causing distress to the couple, then it is termed as FSIAD. The sexual response cycle, first introduced by Masters and Johnson in 1966, he has given a linear model of excitement, plateau, orgasm, and resolution. After him, Mr. Kaplan has given a model of desire, excitement, orgasm, and resolution. This is how a sexual response works. What happens whenever there is excitement? Parasympathetic nervous system works on causes arousal. Then there are few neurotransmitters which act as a excitatory and inhibitory. Dopamine acts as a excitatory and serotonin as a inhibitory centers on the brain. This all leads to plateau. Whenever then there happens some physiological changes like enlargement of the clitoris, there is a pre-vaginal arterial dilatation, expansion of the inner 2/3 of the vagina. And this all leads to orgasm, during which outer 1/3 of the vagina becomes congested, there is tightening, involuntary contractions of the pelvic floor muscles occurs, there is increased heart rate, BP, and respiratory rates. This all leads to resolution. We all know that females gets multiple orgasms, but men they don't because of their refractory period. How these factors contribute to desire? There are a few factors like drive, which is a biological component, motivation is a cognitive component, and responsiveness to sexual stimuli. What happens about the drive? It is an instinct, innate reaction, which represents the spontaneous desire. During motivation, this is a psychophysiological phenomena, and it is linked with the cognitive process. During this motivation, the female desires for sexual pleasure, intimacy, they please the partner and feeling desired. Sometimes there is emotional or narcissistic satisfaction, and sometimes motivation is because of financial gains, like what happens during prostitution. Responsiveness to sexual stimuli is to induce the desire, arousal, and behavior, and this becomes a personal sexual script. How we classify? There are mainly 3 problems, female sexual desire problems, like female sexual interest and arousal disorders, orgasmic disorders, and genitopelvic pain and penetrative disorders. Previously, sexual aversion disorders were also capped in this list, but now they are came under phobic disorders.
There are few categories like subjective, genital, and combined categories, depending upon the symptoms the woman is suffering of. And these disorders may be lifelong or acquired, and it may be generalized or situational. What are the etiopathogenesis? This problem is very much complex. It involves hormonal, neurobiological, and psychological factors. And excitatory neurotransmitters which act on the brain are dopamine, estrogen, oxytocin, and testosterone. And inhibitories are serotonin, prolactin, progesterone, and opioids. This slide shows how positive influences and inhibitory influences act on desire, arousal, and orgasm. Is there any gender difference? Yes. Female passes through lots of changes during her life cycle. There are hormonal changes starting from the puberty, adolescent, then when she gets pregnant or lactating or pre and post-menopausal, lots of hormonal changes occurs. Similarly, there are pressures of the work, family pressures. She gets stressed, fatigue. So we cannot prescribe a blue pill to each and every woman. We have to individualize the treatment. This chart shows how the estrogen, testosterone, and progesterone variations occurs throughout a female lifespan. The causes are aging. That is the most important cause. As the woman pass her age, there is a changes, and she thinks her family is now complete. She doesn't require any sex, but it is not so. Similarly, some medical comorbidities like diabetes, hypertension, thyroid problem, or other hormonal problems, they affect her sexual life badly. Psychological and personality issues. Sometimes patients feel that she has low body image, low sexual and autonomy. There is negativity, absence of erotic thoughts, relationship issues, or some past traumatic experiences like rape or childhood abuse. They all affects her sexual life. Hormonal changes, as I have already told, some drugs like oral contraceptives, antidepressant, antihypertensive, SSRIs, they all negatively affect the sexual life. Gynecological intervention, episiotomy, previous vaginal surgery, cancer surgery, chemotherapy, radiotherapy, or many times sexual dysfunction of the partners. The prevalence rate is very high. According to National Health and Life Survey and PRECISE study, it is 43% of the women worldwide affected with some or other sexual disorder. In spite of such high prevalence, only 1 woman out of 10 seek help for this problem. How we can diagnose? History plays very important role. We have to take a detailed social history, her relationship, her substance abuse, any sexual abuse in the past. Then sexual history should be taken in detail. I will take it later. Medication history, whether patient is on some medications, is there any drug abuse or alcohol abuse, then past medical history, history of pregnancy or recent childbirth. Then examination should be done thoroughly. So detailed general, systemic, and mental state examinations. Pelvic examination should include PS, PV, vaginal swab, see for any scars or operation injuries. How we take sexual history is very important. We have to ask who initiates, what is her preference, what is the frequency of coitus, is the type and amount of genital stimulation is adequate for her or not, how is the lubrication, what is the length of time of intercourse, whether she is able to achieve orgasm, does she experiences any pain, is there any distraction, stress, or fatigue, or is there any partner's problem? So we have to ask in detail personally with the female women and then with the couple also. We have some screening tools available with us. They help in reaching the diagnosis, like decreased sexual desire screener, female sexual function index, HASDD, and promises screener. This is desire screener. In this, it is an auto-rated women screener. In this, there are 5 questions available, and female has to reply in the form of yes or no. And this helps us in reaching the diagnosis. This is the questions of the decreased sexual desire screener. What investigations we should do? Apart from routine investigations, hormonal profile like thyroid, prolactin that plays very important role in sexual life. Testosterone is important, estrogen, progesterone, FSH and LH should be done. Apart from general testing, we have some specific testing for this, like genital blood peak systolic velocity with duplex ultrasonography study, vaginal pH, intravaginal pressure volume changes, and genital vibratory perception thresholds. But they are not very significant for clinical practice. Now come for the management part. Non-pharmacological management is very important. We have to advise them lifestyle changes. They should exercise regularly. They should keep time for intimacy, sexual experimentation. They should avoid tobacco and alcohol, and practicing stress relieving techniques like mindfulness-based interventions, yoga, meditation, that all helps a lot. Initial counseling should be done for the women alone, and then the couple counseling should be done. We have to build the rapport properly, provide them safety, security, and privacy. That is very important. Otherwise, they will not open up with their private life. Cognitive behavioral therapy is important. That helps in HSDD. Then psychotherapy is a recognized treatment for HSDD. This modifies the thoughts, beliefs, behavior, and emotions and relationship issues which interferes with the desire. For this, we have Placid model, Allows model, and Maybe's model. Sensate focus therapy, as advocated by Masters and Johnson, is very helpful technique. This is a series of graded touching exercise which reduces anxiety and it improves intimacy. It works by refocusing the participants and couple on their own sensory perception and sensuality rather than thinking of goal-oriented or penetrative sex. This helps in improving and realizing the pleasure and self-exploration. Similarly, mindfulness-based sex therapy helps in decreasing the cognitive and affective distractions and reduces the performance anxiety. This is how we should help the couples by not opting for things which is distracting in their sexual life or intimacy. We have some pharmacotherapy available with us, like flibanserin, which is a FDA-approved agent. Dose is 100 milligram once daily at bedtime, but side effects is severe hypotension and syncope, and it is contraindicated with alcohol and hepatic impairment. Testosterone is widely used. It is off-label treatment for mainly for peri and post-menopausal women, available in the form of patches like 300 microgram or gel 1%, should be given for 3 to 12 months. If it is given in this dose, then the side effects are mild, like hirsutism and acne. But if it is given for prolonged period of time and in excessive dose, then there is deepening of voice or clitoromegaly may occur. Buspirone is serotonin alpha partial agonist. It is used as anxiolytic, and the dose is 5 milligram BD. It is off-label treatment for HSDD. Bremelanotide is US FDA approved drug, is very useful in HSDD. It is available in the form of injection, 1.75 microgram subcutaneous injection, should be given once in 24 hours before activity. But it increases blood pressure, and if it doesn't work, it should be stopped after 8 weeks. Bupropion is another antidepressant drug. Some other drugs like also available, like tropical prostaglandins, oral oxytocin, ginseng, and ginkgo biloba. Then we have some combination drugs like testosterone with buspirone and bupropion with trazodone. These are under trial, but they are quite effective. Hormonal therapy for menopausal women, systemic HRT that improves the sexual function and dyspareunia, but we have to assess the risk benefit. And once we start therapy early in menopause, that is a great advantage. Another drug is tibolone, is androgenic, but the advantage of tibolone is it doesn't stimulate breast and endometrium. So there is no stress for carcinoma. And this drug is used as a first choice drug in as a HRT in low libido women. So for the treatment of FSIAG, we should engage, the treatment should be comprehensive. We have to involve psychosocial, biological strategies. Counseling plays very important role. We should focus on the most distressing symptoms of the couple. Psychotherapy like the sensate focus, CBT, and mindfulness plays important role. Apart from this, we have pharmacological options like different drugs, antibolon, local lubricant, testosterone gels. They are all widely used and helpful. So in conclusion, FSIAD is a highly prevalent but often underdiagnosed condition, and it can be effectively managed with appropriate assessment and individualized treatment. So what are the points to ponder? Couples should invest in their relationship. They should enjoy couple time. They should grow intimacy and trust. They should rekindle the fiber and be confident of their body and sexuality. They should explore, experiment, and experience, and always seek professional help rather than going to cracks. Communication is the best key. Thank you so much.
Hello.
Hello.
Yeah. So I think Ruma Madam has explained very well about the female sexual interest and arousal disorders. So we have learned many things that we have not read earlier in college time. And even during practice, we are not aware of all these things. So really, we have learned many things. So if any chairperson has come, they will conclude. Otherwise, I think I can say that it's really it's so academic, and so many of us have learned so many things so that we can practice when we get such patient. And we have to take the history also, so that if they have any problem, many couples come, especially women come, my husband wants, but I don't like sex and I don't want. So in that case, we can give some medicine also. I don't know, these drugs which you have mentioned is available here. Fevansherin is available here in our part in India.
Fevansherin is not available, madam. But otherwise, other drugs are available.
Yeah. So okay, we can at least biological counseling should be done first, and we have to tell them the importance of this relationship that should be maintained, and intimacy should be there. So because really, when the woman gets menopause and when the children are big, they don't want sex. So we have to counsel them, and if necessary, we can give the medicine also. So I think it's really very important, very academic session, and we have learned many new things. So thank you, madam, and for your excellent presentation, and it was really wonderful. Any chairperson, if you join, please can share. Otherwise, you can move to next session.
Dr. Neeraj, do you want to speak something?
No. Any drugs nowadays is an issue. If it is not locally available, we can buy it online. So
okay.
What I think, it is a specialized thing. Sexual medicine department is a specialized thing, and you cannot, the general gynecologists cannot take over everything about that. So more and more people should come with the specialty clinic for sexual medicine, I think.
Yeah, but sometimes drugs are not
smaller towns
locally, but you can order it online. So it should not be issue.
Yeah.
If you want to buy something, you can always buy online.
We can take the help of our psychiatric doctors also.
Yeah.
They will suggest us in.
No, but sometimes psychiatrists are also not that much familiar with the sexual.
We can take the
patient on the antidepressant or anti-anxiety.
We can take the help, but they are not very conversant with the real female sexuality.
Yeah.
So we as gynecologists have to take up that specialty in our own charge, and we have to develop that.
This
and
is our domain.
practice.
We should not depend
That will
on
be
anyone
helpful.
else.
Yes, but if the problem is of anxieties, depression, or some psychological,
just as yes, you can take help, but this should be a specialized thing for a specialist. Yes. Anyway.
So, Dr. Apurva, can we move to next session?
Are you
Madan
there?
sir?
Yes,
Madan sir?
Yes,
Okay.
thank you, Kavita ma'am, for your kind inputs. And it was a very
Nivedita,
I think Nivedita has joined.
has entered. Dr.
Yeah,
Nivedita has
Nivedita.
entered just now. She was the
Yes.
chairperson in the first session. Dr. Nivedita, can you hear me?
Nivedita, Dr. Ruma Shukla Madam has just spoken about female sexual interest in arousal disorders. So I think you have entered just now. So do you
Let
want to
her-
say something,
Let her
Nivedita?
first listen, then she will speak in the next session.
Okay. Okay, I think move to next session. Thereafter.
Yes, yes, yes.
Yes.
Is there Dr. Apurva?
Apurva, are you there? You can invite the chairperson of the second session, no problem.
Apurva is not there, no?
Apurva is not there, so somebody else has to take
Okay.
charge.
Let us move to the.
Good evening.
Yes.
Good evening.
Let's move on to second session. The speaker for the second session is Dr. Padmini Prasad ma'am, and the chairpersons for this session are Dr. M.S. Thakur, Dr. Ranjana Jha ma'am, and Dr. Leena Nair ma'am. All are senior and very active OBGYN consultants from Bihar. I welcome all the chairpersons, and I request Dr. Thakur ma'am to introduce Dr. Padmini Prasad ma'am.
Thakur sir, Thakur sir.
Oh, sorry. Oh.
Okay, Ranjana, you
There is
can
only MS
start.
Thakur. Okay.
Mm.
Sorry.
Okay. Where is the CV of ma'am?
Is he there?
CV of Padmini ma'am?
Yes, Ranjana ma'am.
Madam will say, no problem.
Yes.
Madam will say. Padmi madam, can you share your presentation?
CV ma'am का Padmini ma'am का CV किधर?
I myself will put it in. Anyway, I'll
Ek-
start my.
Ma'am is MD in gynecologist. ये एक important बात is the first woman sexologist. इतना मुझे पता है. ये सबसे important बात है. She is holding so many posts. She is member of so many committees. She is author of so many books. So she has recipient of so many awards. So welcome you, ma'am.
Padmini madam is the backbone of our sexual medicine.
CV तो अभी भी नहीं दिखा मुझे. वो तो अच्छा है कि मुझे कुछ
It's
पता था
okay.
पहले.
When I share screen, I will just put it. Don't worry.
And Padmini ma'am is going to speak on female orgasmic disorders.
Yes.
Yes. So please go ahead, madam.
Thank you very much.
Very
I'll share
controversial.
screen. Okay, just I'll give the introduction. Namaste to you all, and thank you very much for this wonderful opportunity. I thank Sexual Health Committee, Dr. Neeraj Jadhav, and all the participating societies which are part of this great webinar today. And you all know that sexual health is about quality of life. Sexual health and function, it describes the quality of life of the woman. Female sexuality is a reality. She is aware of what to expect from her the sexual relationship. Now, what is orgasm? What is interest? Because she has become an educated and thinking individual and working individual with a independent thinking. So these days, the woman herself will come. She will also bring her husband for so many sexual complaints. See, because usually this is described, I don't have desire. I don't reach climax. Trupti nahi milta hai, khushi nahi milta hai. And the husband also will bring the woman and say she is not enjoying sex. I don't know what is the reason. So there are various reasons for that. What is that? That's so nice presentation from Dr. Ruma Shukla about the interest arousal, and so many all in a greater detail. She brought out all the points about interest arousal. So the next stage after the desire and the arousal, and next stage is the orgasm. And if it is a linear model as described by Masters and Johnson, but now this is most of it, some of the women may start the sexual relationship even without having desire. At a later stage, she can just with a good arousal, good intimacy, she can start getting the desire. She can have the arousal, and then she may be able.
Excuse me, Dr. Padmini, your slides are not
Yes,
visible.
this is just an introduction I am giving. I will start with that. No problem. Okay. So this is what it is. Usually the woman will be thinking, why I am not enjoying, what is happening? And some women, 1 minute. Some women even think because just being with a husband itself is an enjoyment, that itself is an orgasm, she never complains. And some ladies will be attaining the orgasm, enjoying still they are worried, why I am not enjoying, why I am not getting orgasm. They themselves do not know what exactly is orgasm, though they will also be experiencing it. So this is what it is. Let us know what is this orgasm all about, because people have got so many beautiful images or the thoughts about this and what it is, because so many things shown in the movies and also the magazines, and whether I am enjoying, whether my friend is enjoying so much, why I am not enjoying. What is all this about? So what exactly is this orgasm, and what to expect and what not to expect, and how you have to view the orgasm. So where is my orgasm? The woman is asking. Women can have multiple orgasms, men cannot. They are actually the sexual athletes, not the men. So women are the sexual athletes and not the men. And there is so many searches, if you see, about the female orgasm, maximum searches are there for female orgasm in the social media or the net. The sexual response depends on a complex interplay of physical, psychological, and emotional factors between two persons. It is coordinated by the neurologic, vascular, and endocrine systems, and influenced by family, society, and religious beliefs. So sex is not a straightforward, simple things. So many things will be acting on that. A disturbance in any of these can cause disturbance in the sexual functioning also. Traditionally, the human sexual response cycle of Masters and Johnson and Kaplan, the previous slide also you saw how it is desire, arousal, plateau and orgasm, and finally a resolution. But women may stop at pre-orgasmic level. She may not reach the orgasm, or she may be able to have multiple orgasm, or she may not have orgasm at all with slow resolution. So there are other newer terminologies which have come up about this orgasm: enhanced orgasm and expanded orgasm pattern, that is ESR and EO, as defined in various resources recently. These are all that where she is able to have multiple orgasm and a heightened the arousal or the climax. And these are also described how the 4-nerve 6 pathway theory of female orgasm. At least 6 pathway orgasmic reflex or systems work during the development of female orgasms. Pudendal, pelvic, hypogastric, intercostal, and vagus nerves constitute the main nerve network system. Also, there are at least 2 oxytocin pathway systems, whereas oxytocin works as a neurotransmitter and as a hormone separately. During expanded orgasms and ESR orgasms, more than one orgasm reflex arch pathway is activated and trigger an expanded orgasm, while many others contribute to the formation of an EO or ESR orgasm. You can see how the pathways and the stimulation, how it is going. Ultimately, all these stimulations, they are reaching the brain, the sex center, and that is sending messages again to the genital region and also extragenital region, which can give rise to blended orgasm or this. So, but still, the actual fact many describe is we have only one type, one orgasm, that is clitoral orgasm in a proper sexual functioning. So what is this female orgasm? Female orgasm itself has been comprehensively defined as a variable transient peak sensation of intense pleasure, creating an altered state of consciousness, usually accompanied by involuntary rhythmic contractions of the pelvic, striated, circumvaginal musculature, often with concomitant uterine and anal contractions and myotonia that resolves the sexually induced vasocongestion, sometimes only partially, usually with an induction of well-being and contentment. So this is, though it is the shortest phase of the sexual response cycle, you can see how so many things are happening in the mind and the body. If effective sexual stimulation continues late in plateau phase, a point may be reached where the body suddenly discharges its accumulated sexual tension in a peak of sexual arousal, which is called orgasm. It is a total body response involving the brain, spinal cord, sympathetic nervous system, peripheral nerves, muscles, CVS, and also genital organs. Orgasm is a brief episode of physical release from the vasocongestive and myotonic increment developed in response to sexual stimuli. Psychologically, it is the subjective perception of a peak of physical reaction. That is what is the definition given by Masters in 1966. The orgasm in female, it can be an intense feeling of physical pleasure at the culmination of sexual stimulation, marked by simultaneous rhythmic muscular contractions of uterus, outer third of vagina, and anal sphincter, and 0.8-second intervals. A mild orgasm can have 3 to 5 contractions. An intense orgasm, there can be 10 to 15 contractions also. So it is a total body response as I described to you earlier, and the different muscles of body contract. There can also be sex flush, which can become prominent. Women describe orgasm as beginning with a momentary sense of suspension, quickly followed by an intensely pleasurable feeling that begins at the clitoris and rapidly spreads throughout the pelvis. Genital sensations described as warm, tingly, and these spread through the body. Finally, most women feel muscle contractions in their vagina or lower pelvis. Which is described as pelvic throbbing. Most women do not ejaculate. Biologically, orgasm is the shortest phase of SRC, usually lasting for only a few seconds, during which time all these contractions and all the variations occur. And this is a time of pleasure and suspended thought. Mind turns inward and enjoys the experience. Orgasm can be mild, intense, or absent. Women's orgasmic capacity depends on her age, sexual experience, sexual stimulation she receives, and her relationship with a spouse. The various terminologies which are described about the orgasm and orgasmia, where there is absolutely no orgasm, whatever way or whatever type of stimulation is given, and she is not having the orgasm. There are multiple orgasm, extended orgasm, pre-orgasm. Just short of the orgasm, she stops at that stage and unable to reach the orgasm. Missed orgasm, she is about to get it, but suddenly she is not able to get it. Elusive orgasm, faking of orgasm. Many women do that. So if just not to disappoint the husband, she fakes the orgasm as though she is so happy and the husband, she is happy with the husband. Let the husband have the pleasure that he has given her pleasure. So the faking of orgasm very commonly done by many loving wives. And simultaneous orgasm, this is another myth which many ladies have or the men have. So both the man and the woman should have simultaneous orgasm. It is not so. The woman can have orgasm earlier along with the husband or after the ejaculation also. So this, if they specifically try to coincide with each other's orgasm, that can still happen. And this various types of orgasm which are described by clitoris orgasm, vaginal orgasm, we still do not know. It could be caused by stimulation of the G-spot or maybe indirect stimulation of the clitoris or something else entirely. Because the vagina is also surrounded by the clitoris portion of the erectile tissue, and that is the indirect stimulation which ultimately stimulates the clitoris. Exercise-induced orgasm. Exercise, particularly weight training, cardio, and abdominal-focused exercise, sometimes can induce orgasm. Orgasm during sleep. This is also still we do not know. It could be caused by sexual dreams or stimulation caused by bedding or nothing at all. Other things like stimulation of the nipples, anus, and other sensitive areas. So everybody is different, and the stimulation each woman requires or needs can be different. So these are all the orgasms described. A combo orgasm can be achieved by pleasuring the vagina and clitoris simultaneously. The result can be a powerful climax that one can feel inside out. Both the hands can be used to double the pleasure or combine fingers and sex toys. So this is the rabbit vibrator, which can stimulate both the clitoris and the vagina. Many people use it. And cervical stimulation, because we'll be thinking after removal of hysterectomy, what will happen to the sexual arousal or stimulus? They still think that the cervical stimulation is also important for a proper sexual pleasure. It has the potential to lead to a full body orgasm that can send waves of tingly pleasure from head to toe. So this is specially stimulated in the doggy style position, which can allow deep penetration to try being on all fours, a penetrative toy, or the partner. The clitoris, this contains a bundle of nerve endings and is located in the front of the female vulva and under the clitoral hood. So recently, a lot of studies are going on about the clitoris. Earlier, they were thinking that there were 8,000 nerve endings, but now with the recent findings, again, 14,000 nerve endings are there in clitoris, and it is bundle of nerves, which is responsible for the climax or any type of orgasm ultimately. So the clitoris, which is similar to penis, will swell, enlarge, and become more sensitive as a person becomes more sexually aroused. You can see here in the picture how it is. Only the tip, but that's what we are seeing under the hood, and deep inside it extends the whole, that corpus cavernosum and crus of clitoris extends and surrounds the vagina and other regions in the vulva. So direct or indirect stimulation of the clitoris can lead to orgasm. The fingers, palm, or a small vibrator can also help to have a clitoral orgasm. When one feels pleasure intensifies, apply even more pressure. But the other thing one has to know that after a particular phase, the clitoris stimulation, that direct stimulation of the clitoris can be irritating, and also the woman may not enjoy the stimulation of clitoris of a particular stage. But that's why there is a nature which covers the hood, that's the clitoral hood, which covers the tip or the glands of clitoris. So avoid direct contact. Although the few people are able to climax with vaginal stimulation alone, it sure can be fun trying, because most of the time the woman may not enjoy or reach climax only by the intercourse. That's why the man sometimes does not know where to stimulate and about the clitoris and stimulation. So only with the intercourse, only with the vaginal penetration, most of the women do not get the climax. The front vaginal wall is also home to the anterior fornix or A spot. Older research suggests that stimulating the A spot can result in intense lubrication and even orgasm. To stimulate the A spot, focus the pressure on the front wall of the vagina while sliding fingers or toy in and out. So going higher up. And the other spot is about G spot, which is an area along the front wall of the vagina. For some people, it can produce a very intense and very wet orgasm when stimulated. Fingers or a curved G-spot vibrator is the best way to stimulate. And the G-spot is an area felt through the wall of the vagina, an inch or two behind the back of the pubic bone, near the junction of the bladder and the urethra. And it is made up of the tissues of the clitoris, urethra, and it's also a female prostate gland as described by Dr. Beverly Whipple. Less than 1 in 5 women report being able to orgasm through vaginal stimulation or the G-spot. But the G-spot may be its own structure, but it has also been argued that the G-spot is actually a retracted or enlarged clitoris, or is a set of nerve endings attached to the clitoris. It is also argued that the G-spot does not exist at all. And there are various erogenous zones in the body. That's why all this pleasuring exercise and Masters and Johnson's and the exercises which are always described. So that is a time for the couple to explore their own body and what they like, what they don't like, what stimulation gives them the sexual arousal. The body really is a wonderland. The neck, ears, and lower back, for example, are very rich in erotically charged nerve endings begging to be touched. We can't say exactly which parts of the body will drive one to the brink, but we can tell that everyone has erogenous zones and finding them is definitely worth the effort. Nipples are full of nerve endings that can feel oh so good when played with. When stimulated, they also set the genital sensory cortex ablaze. And this is another thing, the bottom play can be pleasurable for anyone if one has enough lube and take time. Massage the outside and inside of the opening, then slowly and gently insert sex toy or finger into the anus. Try a gentle in and out motion. So different people start having the different type of sexual activities. This is another thing which has been described. Exercise, especially weight training, cardio and abdominal focused exercise, can induce orgasms. This is also known as orgasms. This makes sense biologically, as both exercise and sex can stimulate the muscles around the genitals and can lead to increased blood flow to the area of the body. Exercise may also influence our mood via endorphins and other neurotransmitters similar to sex and orgasm. The orgasms during sleep. Many people experience sexual arousal or orgasm during sleep. It is difficult to say what or how exactly this happens. And it's also difficult to research. And is female ejaculating a thing? So there are that's really described, a small percentage of women are able to ejaculate and a small amount of fluid can come out, but which is not always. And there is a difference between female orgasm and also the male orgasm, especially in terms of the ejaculation and the man having a refractory phase. What is this? So now after learning what is this orgasm all about and how they can reach the climax, female orgasmic disorder is characterized by a persistent or recurrent distressing compromise of orgasm, either in frequency, intensity, timing, and or pleasure associated with sexual activity, and it's for a minimum of 6 months. Then only we call it as disorder. Persistent or recurrent delay in or absence of orgasm after a normal excitement phase, causing marked distress or interpersonal difficulty. And similarly, like other disorders, it can be primary, secondary, situational, or global. So this is what is described, how the frequency, it can be diminished frequency, there can be diminished intensity, and timing. It can be a delayed orgasm or it can be a premature orgasm. And the pleasure component, even with the orgasm, the woman may not feel the pleasure. The global study of sexual attitudes and behaviors found that for women aged 40 to 80 years, inability to achieve orgasm varies across the world and regions. So ranging from 10% to 34%. So there is considerable variation in the prevalence rates of orgasmic dysfunction. And this is all the studies which they have conducted and how the orgasmic dysfunction or the satisfaction and about the desire, arousal, lubrication has been given. 5 to 10% of women really have anorgasmia. By any means, they are not able to reach orgasm. 90% they are orgasmic by some means or the other. 50% climax during coitus. So various risk factors like temperamental factors, psychological factors, and environmental factors, which are strongly associated, like socio-cultural factors. And it is for a woman, she should not enjoy sex, she should not have climax, and she should not do these activities, and to talk about sex is a bad thing. So there are certain cultural inhibitions and social inhibition. And there can be some genetic components also that basically their arousal and the activity of the sex center, the biologically itself, they may be having less desire or less capacity for sex. And various causes of orgasmic disorder. It can be an organic cause or it can be non-organic cause. In organic cause, there are various medical conditions like diabetes, menopause, and surgical conditions and psychiatric problems and medication. They can cause orgasmic disorder. And non-orgasmic disorders like improper technique. Most of the time, if the husband does not know what the woman expects, how to take her with a proper foreplay and the arousal and inadequate stimulation, and if he is suffering from premature ejaculation or erectile dysfunction, the woman is not enjoying or she is not. That's why so many times when the husband brings the woman for consultation, when the husband goes out, he says, he has got a lot of, he discharges so fast, I don't enjoy. And he has got problem and it is not becoming hard. And he does not stimulate me properly. And he hurries up for the penetration. So these are all the complaints the woman can give, or she is stressed out and but the work home balance if she is not able to maintain, work for pressure from the children, workplace and the home. So she will not be able to enjoy her sexual relationship. So even the simple day-to-day stresses can affect the sexual disorder. What is the prognosis? Little is known about the natural course of female orgasmic disorder or about the prognosis for women with untreated FOD. Some cases of the acquired and situational type seem likely to resolve spontaneously, but patients with lifelong and generalized types of FOD appear to have a good prognosis with treatment, but an uncertain prognosis without treatment. So the medical history is very important. Chronic and acute medical conditions, medications, substance abuse, and sexual complaints and good sexual history will definitely give rise to the cause of the orgasmic problem, or the careful cardiac, pelvic, and neurological examination, coexisting medical conditions, and also whether there is primary orgasmic disorder. The mild, anxious, or depressed mood or affect is sometimes noted in women with orgasmic disorder. And you were talking about the psychiatrist treating the sexual function. The sexual function can lead to anxiety, depression, and disturbed interpersonal relationship because of the sexual dysfunction itself. Or the severe cases of anxiety, depression, and the mood disorders and psychiatric problems can also affect the sexual functioning and also the orgasm. This is a cause and effect relationship, but most of the time, so sometimes the psychiatrists, when they're putting them on for a normal woman, so they can cause even more problem with the sexual relationship. So sexual problems can be either a cause or a consequence of depression and anxiety. So laboratory workup, like any other, whether the complete blood count, whether she is anemic or whether there is diabetes, and chemistry, all that renal function, LFT, like any other disease, to know the general condition. Hormone panel, because the hypothyroid women can have low desire and unable to reach orgasm, and estrogen effect in the perimenopausal, FSH, prolactin can also be a depressant, and these some of the vitamin deficiencies. So treatment approach considerations, psychotherapy and pharmacotherapy. Women are encouraged to take responsibility for their own sexual pleasure during foreplay, coitus, and afterplay. Suitable environment, relaxed atmosphere are very important, because so many times when the woman comes and complains about this not enjoying or reaching the climax, when I asked her whether you take any, she does not take active participation at all. She becomes a very passive partner. That's why the woman also should take responsibility for her own pleasure. She should also understand her body, and with the masturbation, she can also learn at what level of stimulation she is able to reach the climax. She can apply that during the sexual intercourse, because only with the husband's stimulation and participation, many more than 50% women will be unable to reach the climax. So the woman also should be, when counseled, to take responsibility, understand the body and understand sexual response cycle, and also the active participation in the sexual relationship. So the management issues in orgasmic disorder, number one is education. Most of the time, the lack of knowledge itself is responsible for the problem, either in the form of interest arousal or if the orgasm, when the other things are not happening. So counseling and education leads the treatment aspect for any type of orgasm, this sexual dysfunction. Directed masturbation, and so many times they're scared to touch their genitalia, and masturbation, so much of taboo attached to it. So can I do that? Can I touch this? And if I do, is it not a wrong, doctor, to touch and then masturbate? I was so scared when I once did that. So they were not aware of what it is and about their body. Erotic fantasization and body journey. So they should be able to fantasize the whatever that they have seen, certain movies, they have read certain romantic novels, and whatever that they stimulates their mind. So that is the fantasization that also they should understand. And the mechanical aids and vibrators can be used, and manual clitoral stimulation by the partner, and also sensate focus exercises. Although portrayals of orgasm in media, partners' expectations for our orgasms, and our own interest in experiencing orgasm can make us feel like we need to have an orgasm every time we have sex. A happy sex life does not necessarily mean having a mind-blowing orgasm during every sexual experience. This one has to understand. It is not necessary that each and every encounter of the sexual intercourse should result in such a mind-blowing orgasm. Because sometimes, like any other body function, like digestion, sleep, and food and hunger, so they can have some variations in the body. Similarly, even in the sexual relationship, sometimes it is good, sometimes it is not so good, sometimes they enjoy it well. So they should not make it a big issue about this, that thinking that they have got some disorder. So that also has to be the unrealistic expectation. That also should be counseled properly to the women. Orgasm is just one of many important elements to sexual satisfaction. Many people report that not all orgasms are the same, which makes sense. Our minds and bodies change from day to day due to mood, health, stress levels, etc. It is unrealistic to expect any type of stimulation to elicit the same experience every time. So orgasms are difficult to study. This is another thing. Similar to studying mood or pain, female orgasms need to be interpreted through not just biological mechanisms, but also psychological, sociological, and historical trends. Historically, in Western countries, female orgasms have been highly scrutinized. Orgasms were sometimes seen as unhealthy or wrong, and orgasms that are achieved through stimulation that is not heterosexual vaginal intercourse have been considered unacceptable by researchers and doctors. Sigmund Freud, he popularized the idea that mature women experience vaginal orgasm while immature women enjoyed clitoral orgasm. So in the history, a lot of things attached to the orgasm and female sexuality itself. So many people feel that orgasm is a requirement for happy, meaningful, and fulfilling sex. Some people also feel that orgasm should be reserved for sex as opposed to experiencing orgasm during masturbation. Orgasm is great, but feeling pressure to have an orgasm or a certain type of orgasm at a certain time can make sex stressful and unpleasant. Intimacy, sexual pleasure, sexual satisfaction do not depend on orgasm always. So this is the proposed algorithm for the management.
Padmini ma'am, sorry to interrupt.
No, that is
Actually,
the
it's going to, but
is the
yeah,
last slide. This is
complete.
so depending
Thank
on
you so
the
much.
cause. Yeah, depending on the cause, you are treating this according to the medical condition and lack of knowledge and psychological conditions and other things. So that is what is orgasm. So the one thing is understand orgasm, understand the body, and at the same time don't have unrealistic expectations. Thank you very much for the patient.
Thank you so much, Padmini ma'am. It was always, your lecture is always eye-opener for all of us. So thank you so much for this wonderful lecture. I would like to invite our chairperson, the very dear Dr. Leena Nair ma'am, for sum up or for giving the comments. Leena ma'am. And
Yes.
sorry, because at the beginning, ma'am, when your lectures is going on, there is some net issue. So there's a disconnect automatically. So sorry for that. And Neela ma'am, please,
Yes,
over to
yes.
you.
So thank you, Padmini madam, for that very detailed talk on female orgasmic disorder. As we all know that discussing about sex is a taboo in our society. So your lecture has really been an eye opener for many of us. Even we don't know many aspects of orgasm and orgasmic disorders that you've spoken about so much in detail. I would like to just ask you a question. I mean, does it change with the age? Like around menopause, does the type of orgasm a woman has, does it change qualitatively?
Though she has interest because of the changing state, and that's why GSM we call it as of the menopause, syndrome of menopause. So because of the estrogen deficiency and then because of the changes in the genital region, so that sometimes they may not be having the intense pleasure or the intense orgasm which was experienced in younger. The other thing is because of the dyspareunia or the burning and irritation and then even painful intercourse. So that itself can put her off and they may not be able to reach orgasm. She may start avoiding, even though she has interest, she may start avoiding intercourse because she is not enjoying because of the pain. So they have to treat that, the basic cause of that orgasm. So they may come with, I don't have interest. She will be having interest. Because she's not enjoying, she may start giving the excuses. So the overall perspective you have to look into and then help her. Like treat her in the local, we have got local estrogen wherever possible, give it a lubricants, simple lubricant itself and the estrogen medication if it is indicated. So, and then changing some positions and if there is any other local infections, treating infections, diabetes. So it's very common at that age. So depending on the cause, you can certainly give her relief. But the main problem is women do not know. They think menopause is the end of sex life also. So it's the sex life and the menopause end of her the procreation. So that's what she thinks. But nowadays, women are living 1/3 of their lifetime, they are living post-menopause. So what we need is quality of life for her. And many women are marrying at the age of 45. 50 and the companionship and there are so many other aspects of the marriage, the relationship. So sometimes they are willing to have the normal sexual relationship. They would like to have the treatment for their problem. So all that we have to keep in mind. So any lady, if because earlier when she comes at 55 years and complains of sexual dysfunction, people used to laugh. Doctors also used to laugh at her. Oh, already you have finished and you have got children and they have got grandchildren. Why should you bother about this? So that should not be the attitude of doctors. That is very, very important. And if she does not have any problem, the other thing is it's not necessary that you should treat sexual disorders unless it is causing distress for her or for her partner. If both of them are, there are many people, couples I have, postmenopausal, they are not have, they stop having intercourse and both of them are happy, not complaining. So both of us are not interested and we are happy, doctor, like that only. So you don't have to tell them, no, you should have sexual intercourse.
Yeah.
So that is what, depending on their need based and if it is causing distress.
So thank you so much, ma'am, for that detailed talk on female orgasmic disorder. I think it will go a long way in making other people aware about how to approach a patient who presents to you with female orgasmic disorder. It is very important to create awareness, not only amongst the doctors, but also amongst the lay people who are not very aware of their sexuality and how to approach a problem if they have it. So thank you so much for that very comprehensive.
Gynecologists need to answer their questions because nowadays they go to net, they study so much, they read so much and they come and ask you why I am not enjoying, why I am going. So you should be able to answer their questions and help them. So
yes,
gynecologists, it is extremely important to know.
It's very important for us also to be aware how to approach these kind of patients. So thank you so much for opening our eye regarding this female orgasmic disorder. I think, Ranjana, would you like to say something?
Yes, excellent talk, ma'am. Ma'am, I have one question, that is vaginal delivery reduces orgasm?
What happened?
Vaginal delivery reduces.
Does
orgasm.
it reduce the
disturbance, I think, in vaginal delivery? Does it reduce?
Yes.
Orgasm, you mean?
Is there any difference between vaginal delivery and cesarean section for getting orgasm?
Yes. Number one, see, sometimes if the episiotomy and then the lax vagina and becoming loose vagina and episiotomy not sutured well, so many ladies these days they're coming and I have done this pelvic floor repair and tightening because that is because of the loose feeling itself, that it's not giving proper grip to the penis and the stimulation is not there. So that's why they are not enjoying. So many times they are having this problem, but they don't know whether to tell it or whether they can get help. So nowadays, because when they know that, they can come and have this vaginal rejuvenation has come as a part of all this. So it's they can enjoy the sex better if there is a proper grip. Are there? Because if the vaginal delivery with the cesarean section, not so much of changes which can happen below. But with vaginal delivery, so make it a point when you are during antenatal period and when you are sending her home post delivery, give a proper sexual, take a proper sex, give proper advice to her when she can restart her sexual activity, what she can expect, and if there is any pain or any problem, please come and report. So it's very important. So because
many patients are coming after delivery that with this problem.
yes, that you can help them, and then you examine if you think there is a lax vagina and there's some part of say rectoceles like that.
So will PFR will improve her?
Yes, definitely.
PFR?
Yes,
yeah.
We forget the importance of the postnatal exercise. We hardly advise them.
Yes.
No, that is a part of your. It should be a part of your advice. Kegels exercise. It will improve the tone of the muscles. Definitely, there will be lax levator muscles that will improve the tone and that will help her. So and it will also prevent some of the urinary problems, delivery stress incontinence.
Thank you, ma'am. Thank you.
Thank you, ma'am, for that excellent talk.
Thank you so much.
Thank you so much, Padmini ma'am, for the wonderful talk, and to the chairperson, very dear Dr. Leena ma'am and Dr. Ranjana Jha ma'am for chairing the session so well. Thank you so much, ma'am. So coming to the next talk, we have a very three senior most gynecologist with us. I would like to invite Dr. Sipra Singh ma'am. Sipra Singh ma'am is at present the secretary of the Saharsa Society. Thank you so much. Katihar. Katihar ma'am. Katihar. Sorry, ma'am. Present the secretary of the Katihar Society. Thank you so much, ma'am. Welcome, ma'am, for joining this webinar. Second, we have Dr. Sangeeta Thakur, ma'am. Ma'am is at present the secretary of the Saharsa Society. Sir, thank you so much, ma'am, for giving us the time and for your valuable coming and joining this webinar. And third, we have Dr. Sadhna. Ma'am, Sadhna ma'am is at present the secretary of the Muzaffarpur Obgyn Society. So welcome to all the chairperson, and I would like to invite Dr. Sipra ma'am to introduce our next speaker, Dr. Monica Gupta ma'am. Over to you, Sipra ma'am.
Thank you. Good evening, everybody. Thanks for organizing such a good webinar. So informative. We are learning some new things. So this is my turn to welcome Dr. Monica Gupta ma'am. Please show her CV. She is the president of Alvar Obs and Gynae Society, and she has been awarded the Achievers Award during the Yuva Foxy West Zone at Ranthambore, and she was also the organizing president of AlvarCon 2023. Please, I welcome you, madam, to start your presentation. Dr. Monica Gupta, madam.
Thank you, ma'am. Thank you for the kind words. And I really thank Dr. Neeraj Jadhav, Chairperson, Sexual Medicine Committee, all the chairpersons, all the faculty.
I think you
Dr. Monica, you've joined from 2 sets.
So just
Hello.
Monica, you can switch off from one device. You are I think from the 2 device.
No, sir.
Your voice is echoing.
But sir, I don't know. I'm only with one device only.
Because your voice is.
Are you using some earphone or something like that?
No.
But
Nothing.
your voice is echoing.
I don't know why.
Ma'am, if you have a mobile or something, just keep it away. Probably that will be a.
I'll just keep it outside. Now it's okay.
No, ma'am. Again, it's echoing.
It's echoing is still echoing.
Now I have to. No electronic device in my room.
You can do one thing, ma'am. Neeraj sir, can she log out and then again log in?
Yes.
Ma'am, please you leave the meeting and then again rejoin it.
Okay. It's difficult.
If there is a delay, can we proceed to next session?
Yes, yes. I think can finish it.
Dr. Purva, I think we should move to next session. By the time
Yes, yes.
she
Okay.
will rejoin.
Okay, ma'am. Okay, ma'am.
Because
Okay.
it will save the time. Yeah.
Madan sir.
Yes. Okay. Okay, we will move on to next session, session 4. For this session, we have Dr. Pratibha Singh as speaker, and the respected and senior chairpersons, Dr. Alpanam, Dr. Yadav, and Dr. Lata as esteemed chairpersons.
I think Lata, you should introduce Dr. Pratibha Singh.
Yes, madam. Yes, good evening, everyone. First of all, I thank the organizers for giving me an opportunity to chair this session, and that too, Madam Pratibha Singh's talk. I'm really overwhelmed. She doesn't need any introduction. She is a consultant laparoscopic gynecologist and IVF specialist, and she's a director of Healing Touch Hospital, Bhagalpur. She's a dynamic gynecologist, and she's one person who represents Bihar and Jharkhand at the national levels. Recently, she was elected as a chairperson for the International Academic Exchange Committee, and she's doing a lot of work, academics, conducting CMEs, taking part as a speaker, so many things. Really, madam, we are inspired by you, and we would like to follow your pathway. So please go ahead with your talk.
Thank you, Dr. Lata. I'll request the host to kindly disable my screen. My screen is not. I will ask the host to kindly disable my screen. Yes, thank you. Can you see my screen?
No, not.
Yes.
Is it full screen?
No,
Yes.
no, it's not full screen.
No.
Huh?
It's not full screen.
Now it is full screen.
Ma'am. Yeah.
So, respected chairpersons and my dear friends, a very good evening to all of you. And first of all, I would like to thank my society, especially President Dr. Rekha Jha Madam,
and Secretary Dr. Kavita Barnwal for giving me this opportunity to address such august gathering. And my regards to all the seniors and all guests who have gathered here today for this webinar. And welcome Dr. Neeraj Yadav virtually to Bhagalpur. And thank you so much for including me in this webinar. And I know it is really very difficult to talk on sex and sexuality, but you have done wonders. You have done so many webinars, so many CMEs across the country. So hats off to you. And now you are starting this ICOG certificate course. So I think it is really, you are really becoming successful in your mission. So congratulations once again. Now, this is for the first time Bhagalpur is holding this webinar on this topic, and I think it will help us to counsel our patient regarding this particular issue. And my previous speakers were brilliant, and the talks were quite informative and bold, and they have done full justice to the topic. And they have also made my job very easy. Now I will be talking on another issue, and that is sexuality in pregnancy, and which is again quite neglected part of our antenatal practice. And if at all we talk about sex, we always talk about abstinence or no. Like in first trimester, we'll say abstinence, maybe you will land up into miscarriage. In second trimester, because of bleeding, we say no, no sex. And in third trimester, again, a big no, maybe you will land up into premature delivery. So most of the time couple feels that there is abstinence for almost 9 months, or rather I can say abstinence for almost 12 months, which is not right, because many of the patients, they are normal, they are comfortable during pregnancy, and they can have sex during pregnancy. So that is what I'm going to talk, and I think I'll do justice. I hope I do justice with the topic. To be a mother is a natural instinct, and sexuality is an important part of health and well-being. Both pregnancy and sexuality are natural and normal phenomenon of women's life. Marital success and failure may be related to sexual function. Now, sexual behavior modifies as pregnancy progresses, and it is mainly influenced by biological, psychological, and social factors. Women's sexual function is a complex interplay of physical, psychological, and emotional factors, and especially when she is pregnant, because during that time, the interest in sexual activity may be affected by her changing physical appearance and the hormonal milieu of pregnancy. And many a times, the expectant mother, they are not very happy, or they don't want to get indulged in sexual activity, but they will be feeling more happy by increased physical contact, just like cuddling or being held. Now, from the obstetric standpoint, the physical changes of pregnancy are obvious, but the connection between these changes and sexuality often is not very clear, either for the doctors as well as for the patient. Normal physiology becomes a source of numerous deterrent to sexual activities and can affect the women's sex drive in either ways. Higher levels of estrogen and progesterone, as well as increase in blood flow into the genitals, can lead to heightened sexual desire in few, while on the other hand, nausea, fatigue, and stress, and many other physical changes can reduce women's desire to have sex. But there is an established fact that it is common for women's sex drive to decrease during first trimester, peak in the second, and again it goes down in the third trimester. Now, what are the psychological aspects of sexuality in pregnancy? And the major concern here is loss of attractiveness. Most of the time, the pregnant female, she feels that she doesn't look very beautiful. Her contour has changed. So that can precipitate psychological conflicts in a woman that has not previously arisen. Either the direct verbalization of disinterest or the subtle avoidance behavior, which she feels that husband is avoiding me because I'm not looking that great, or I'm not looking that beautiful, which I was before. So that causes disharmony in their marital life. There is drift between them, and this sometimes can perceive tendency for men to have involved in extramarital affair. The background to this psychological factor is again the unspoken fear by both partners that penile penetration can cause injury to their fetus. Now here comes the role of we healthcare providers to disseminate the truthful information and help them to minimize or eliminate these unsubstantiated fears. In general, a woman's sex drive with ebb and flow throughout her pregnancy. Although every woman's experience is unique, there are few common trends which occur during pregnancy, like there is increase and decrease in libido, which both are normal. Some women have higher level of arousal and more intense orgasm during pregnancy, while others notice almost opposite. Many couples, they don't have sufficient knowledge regarding sex during pregnancy, so they themselves self-impose abstinence on them. Although the couple will have plenty of questions regarding sexual activity during pregnancy, but because of taboo attached to sex, and many a couple, they feel shy and are hesitant to discuss the issue with their doctors. Even we doctors sometimes think that it is not an issue to discuss. But unless you are familiar with the scientific data, the potential for providing patients with misleading or incorrect information is quite high. Like there was a survey done and they found that around 49% of women were concerned that intercourse could harm their pregnancy. And 91% of pregnant women met the cutoff of sexual dysfunction in female sexual function index as compared to 68% of their non-gravid female counterpart. Also in pregnancy, various hormones affect physical and mental aspects, which can have an impact on sexual functioning. Like progesterone is responsible for physical and mental changes, whereas estrogen can affect sexual desire and function, whereas oxytocin, which is released during orgasm, can cause uterine contraction and can sometimes cause discomfort to pregnant female. Then prolactin increased levels can affect sexual desire. So you have to counsel your patient properly that pregnancy and childbirth is not a disease and sexual relationship is a part of quality of life. Couples should not be dying of sexual pleasure and happiness unless there is any complications. So these are the conditions where you must avoid pregnancy. Okay, Dr. Indrana, please mute yourself.
Kindly mute.
So what are the conditions where you should avoid sex during pregnancy? That is when there is an increased risk of miscarriage, or when there is unexpected vaginal bleeding or leaking occurs, or when you have already diagnosed placenta previa. In that case, sex should not be sexual activity should not be done during pregnancy, and when she shows the signs of preterm labor. Now, what are the causes of decrease in sexual activity during pregnancy? It is mainly the awkwardness of the couple to have coitus during pregnancy, maybe fear of having injury to their fetus, or because of some hormonal changes like decreased libido, dyspareunia, fatigue, breast tenderness, genital vasocongestion. Then because of the changing body contour, which with which the female become quite uncomfortable, then physical discomfort, or sometimes urinary frequency and urgency after intercourse. And during postpartum period, it is mainly because of vaginal soreness due to normal delivery. There may be episiotomy pain, dyspareunia, fatigue, milk leakage, nipple tenderness, and sometimes sexual role changes. She feels that now she is a mother, so she has to look after her child rather than indulging in sexual activities. So here, let us get aware, let us talk about sex, and we as doctors should answer the queries of the couple. Most pregnant women can engage in sexual activity throughout pregnancy in the absence of any complications. Although sexual desire, libido, arousal, orgasm may vary during all the 3 trimesters, but most important thing is that if you don't go for intercourse also, couples should have some level of intimacy, should be going on throughout the pregnancy, so that will help them to keep the relationship healthy. Also, there are certain advantages of sex. Like there was research studies in 80s and 90s, which indicate that overall sexual satisfaction was correlated with feeling happy about being pregnant, feeling more attractive and experiencing orgasm. Also, when sex is done in the later part of the pregnancy, that is at the time of delivery, sometimes it causes induction of labor because natural prostaglandin content of the seminal fluid can favor maturation process of cervix and make it more flexible, allowing easy dilatation and effacement of the cervix. Another interesting evidence is that exposure to the partner's semen prevents preeclampsia due to absorption of several immune modulating factors present in seminal fluid. It is 100% correct that sex feels different during pregnancy. For some, it is more pleasurable, where for others it is less. Increased blood flow to the pelvic area can cause engorgement of the genitals, which may give uncomfortable feeling of fullness for few, whereas for others, it can heighten the sensation and may add to the pleasure during sex. Also, vaginal discharge and moistness can help easy penetration. During orgasm, release of oxytocin may sometimes cause uterine contraction, which may cause discomfort to the females, and they avoid sex for that. Breasts sometimes feel tender and unusually sensitive throughout, so some women may prefer that their breasts are not touched at all during intercourse. Even for males, they feel attracted as usual during first and second trimester, and they feel less interested in third trimester. And the reason for this lack of desire for the daddy to be fear that sex can hurt the baby. Second, they worry about their wife's and unborn baby's health. And again, apprehension about burden of parenthood and self-consciousness about making love in the presence of their unborn child. Now, another question arises, is it normal if there is no sex during pregnancy? So answer is yes, it is normal. Pregnancy hormone can reduce libido, but what is normal for one person is not necessarily be normal for other also. And it is the mindset of the pregnant female or the couple, how they feel about the sex. So if one feels positive about pregnancy and the associated changes, then she will be feeling more sexual and she will be happy having sex during pregnancy. But if the woman is unhappy or feel insecure or have relationship problem or it is an unwanted child, in that case, it can have negative effect. So this is the cross-sectional study which was done in St. John's, Newfoundland, Canada, to evaluate women's sexual experience in pregnancy and to describe their source of information regarding sexuality during this period. And they have taken 140 pregnant women, and pregnant women anonymously completed self-administered questionnaire regarding sexuality and sexual activity during pregnancy. And the response was summarized using descriptive statistics, and comparison was made between the trimesters of the pregnancy. And what was the conclusion? That as the pregnancy progresses, most of the female, they have reduction in sexual activity, vaginal intercourse, and sexual desire. And the cause may be both women and her partner have concern regarding complications in pregnancy as a result of sexual intercourse. Although majority of women wish to discuss these issues with their doctor, but they are not always very much comfortable raising this topic by themselves, so we must initiate such patients. Another study is to evaluate the changes in sexual perception and activities during pregnancy and to determine sexual dysfunction in that period. And here they have taken all delivered patients and they have been asked anonymously, they were asked to complete a self-administered and structured questionnaire on the day of discharge from the hospital. And what they concluded, that sexual satisfaction do not change in pregnancy compared with pre-pregnancy pattern despite a decline in the sexual activity during third trimester. So a discussion of expected changes in sexuality should be routinely done by doctors in order to improve couples' perception of possible sexual modification induced by pregnancy. So with this, I conclude saying that it is a normal for women's sex drive to ebb and flow throughout pregnancy. These changes usually coincide with the physical and hormonal changes that occur each trimester. Pregnant women and their partners can safely practice in most form of sex as long as it is consensual, comfortable, and safe. Communication and openness are the key to maintaining or improving sexual satisfaction during pregnancy. Unless an obstetrician advises otherwise, all types of sex are safe during pregnancy. Only women should abstain from sex if she has high risk for miscarriage or history of preterm labor. We obstetricians have many opportunities during prenatal care to give accurate information and dispel myth. Although many patients may be reluctant, but would welcome a discussion of sexual matters if approached sensitively by their physician. So counseling is very important to relieve the couple's anxiety and enhance adjustment to their changing relationship, which may help to prevent the development of long-term conflict, which usually occur after childbirth. So I end stating this quote, that feeling happy and confident about your sex life is not about how much sex you have, but it is about understanding that you get to decide what is right for you. Thank you so much for your patience.
Thank you, Dr. Pratibha, for such a wonderful and excellent talk on sex and sexuality during pregnancy. At the outset, I would like to pay my regards to all the seniors and my gratitude to the organizers, Dr. Neeraj Jadhav, and my president, Dr. Rekha Jha, for giving me this opportunity. I think this is still an undiscovered topic and less discussed also. And the talk was Dr. Pratibha Singh has given on sex and sexuality during pregnancy is really a wonderful, and you did a full justice to the topic.
Thank you. Thank you.
During pregnancy, the sexual desires actually becoming low, not only due to the hormonal changes, but it is a combination of this physiological, psychosexual, and the hormonal. All the three factors come together for a sexual desire during pregnancy. And here the sexual desire during first and third trimester usually goes down, mainly due to the fear of losing her any damage to the baby. And for that, both the partners are thinking the same thing, that we must have a very safe delivery of a safe baby for which we have practiced sex. And in fact, during the pregnancy, they think that we are going to have an outcome of our sex in terms of a very good baby. So unless and until there is some contraindications during pregnancy, the sexual performance can be done with taking the precautions, because as Dr. Pratibha Singh rightly said, that due to the liberation of oxytocin, it causes the uterine contractions, and this uterine contraction sometimes may lead to the preterm labor. So until unless there is a clear-cut evidence, clear-cut problem, like the is there presence of vaginal bleeding or some placental dysfunction or premature dilatation of cervix, or there is a chance of, or there is a threat of preterm labor, the practicing of the sex behavior during first and last, during the second trimester is safe. And I think we must have a safe sex during first and third trimester, so that there should not be any complications of pregnancy. And so that we can, otherwise the couple will feel guilty due to our involvement in sex, we are losing our child. So everything is very much rational and should be rational. And there may be a very practical approach towards the sex and sexuality during the pregnancy, having a clear-cut balance to have this a very good relationship and understanding between the couple and the pregnancy outcome. At the same time, sometimes I feel during my practice, the female are very much scared about the relationship with their husband, and she is always thinking there may be some extramarital relationship. Yes, this may develop if you are not involving. You must have a very much good relation with your husband. So if you are not involving in sex, but there must be a very good communication and good relation and contact, at least contact relationship with your husband, that may lead to, they may alleviate the feeling of insecurity during pregnancy. So I think Dr. Pratibha Singh has given a wonderful talk, and I must congratulate Dr. Pratibha Singh, and at the same time, Dr. Neeraj Jadhav, the chairperson of this committee, for arranging such a wonderful webinar, because these topics are still undiscovered and less discussed. And we learned a lot by this webinar. Thank you very much. Thank you for including me in this part.
Thank you, Dr. Roma Madam, and for your kind inputs. And congratulations, Dr. Pratibha Madam, for the wonderful and very elaborate talk on sexuality in pregnancy.
Thank you so much. Thank you, Dr. Neeraj, for including me. Thanks.
Thank you, Dr. Neeraj.
Shall we move on to next? Is there
Yes,
Apurva? Dr. Apurva?
Monica is there.
Yes, sir. I'm ready.
Yeah. Okay. Our next session speaker, Dr. Monica Gupta ma'am. I welcome ma'am, and I would like to welcome the chairpersons for this session, Dr. Shipra Singh ma'am, Dr. Sangeeta Thakur, and Dr. Sadhna ma'am, who are the senior consultants of Bihar Society. Okay. Dr. Shipra Singh ma'am, who is the professor, Department of OBGYN, Katihar Medical College, and she has special interest in infertility. And Dr. Leena ma'am is the consultant.
No.
Bhagalpur.
Dr. Shipra.
Dr. Sangeeta, Dr. Sangeeta and Dr. Sadhna.
Sangeeta and Dr. Sadhna Sinha. Dr. Sadhna Sinha, Dr. Sangeeta Thakur. I think let her speak and they will continue.
Yes, yes.
She has already been introduced.
Yes.
So I think
Yes,
let
yes.
her speak, then they will conclude.
Yeah.
That will be better.
Monica, you can start
Okay.
sharing your screen.
I request Shipra ma'am to introduce Dr. Monica.
Yeah, she is already introduced, so let's start.
It's already introduced.
Yeah, so let us start. Monica.
Yes,
stage is
ma'am.
yours. You can
So,
start sharing.
share. So it's not being shared. So you have to ask if Apurva can share for me. There's some now there's a problem with my laptop.
You are not able to share?
Yes, sir.
Dr. Apurva, can you share the slides for me?
Okay, ma'am, have you sent the new one?
Oh, I can speak on the old one also. The same. Which we
Okay,
were
okay,
having
okay.
previously.
Okay, okay, ma'am. Just wait. Have you tried to share, ma'am?
I have tried to share. Before they were there, and now they are missing. All these have got.
Okay, ma'am, you are trying to share, and let me, if not, I'm also sharing it. Okay, ma'am.
Yeah, better because I couldn't find it. कल तो यहीं पे उसका आइकन था. क्या हो गया? व्हाइट बोर्ड पे होगा. व्हाइट बोर्ड पे देखो.
व्हाइट बोर्ड पे
उसमें है तो सही.
को कर दो आप हटा दो.
फाइल्स में. मैंने क्या गया वो बंद कर. तो यहीं पे आइकन आ रहा था उसका. स्क्रीन शेयर हुई मगर वो आई नहीं रही ना यहाँ पे.
Down you take na.
Monica, you minimize the screen first.
हाँ.
Right में speaker view, click on it. Then minimize again. In the bottom there is share screen.
Share screen.
Ma'am, I'm doing it, but I'm not finding my slides over there.
After sharing the screen, you have to minimize the zoom. Then you will find your PPT on your desktop.
पता नहीं अब कहाँ गया ये सब ये निकालो कहाँ गए
Let me try.
Yeah,
हाँ,
you
हाँ.
try.
Okay. It is visible?
And it is
Yes,
visible
sir.
now. I can speak on these.
Okay, ma'am, please go ahead.
Sorry for the inconvenience because of my lack of knowledge about the IT sector. I'm highly sorry to everyone for wasting the time. And I am highly thankful to Dr. Neeraj Jadhav, Dr. Bhagalpur Society and Bihar Society for giving me this opportunity to speak on the topic of vaginismus. As we all know, vaginismus is a major cause for non-consummation of marriage. And it is an involuntary and uncontrolled. Apurva, please backslides. It is an involuntary and uncontrolled contraction of the muscles. And it was first described by J. Madison Sim as a reflex-like contraction of circumvaginal musculature resulting in non-consummation of marriage. Next. It was earlier defined as recurrent or persistent involuntary spasm or constriction of the musculature surrounding the vaginal outlet, especially the outer third of the vagina, and that interferes with the penetration. And now, in 2005, International Definition Committee described it as persistent or recurrent difficulties of the woman to allow vaginal entry of a penis, a finger, or any object, despite the woman's expressed wish to do so. Well, she is willing, but still she has got uncontrolled contraction of the muscle, which prevents the penetration. Next. Basically, female sexual dysfunction are described as orgasmic and interest and arousal disorder, which we have already discussed, apart from pain and penetration disorder, in which vaginismus, apart from dysmenorrhea and non-coital sex pain disorder are there. Next. The prevalence is very difficult to assess because it needs gynecological examination and which patient avoids. In worldwide, around 0.6 to 7% ladies are having vaginismus, but in our clinical practice, we can see as high as 70% of the cases, and still the exact prevalence is very difficult for us to know. Next. The types are primary or secondary. Primary is lifelong. They never had an intercourse, and acquired is where they were having previously no history of vaginismus, but now because of some disease or some trauma, there is a difficulty in vaginal penetration. Second classification is done complete or partial. Complete in which there's inability to place anything in the vagina, and partial in which something can be inserted but not the penis, and situational when in some situation intercourse is allowed and in other it is not. Next. Etiology include organic or non-organic causes. In non-organic causes, psychosomatic disorder, phobia, conversion disorders are there, in which body expresses the psychological fear of penetration as involuntary and uncontrolled contraction. There's a defense contraction of the perivaginal muscles, and there's a negative perspective over sex activity. She feels sex is guilty, sinful, shameful activity, and it is a punishment what she is getting. Next. She can have a homosexual orientation, or she can be having a fear that penetration can cause pain, injury, or bleeding. There is a fear of pregnancy, childbirth, or AIDS. In many cases, there is a history of sexual abuse at the age. Next. Organic causes include lesions of the external genitalia, as vaginismus is a reflex contraction for the pain, hymenal abnormalities, STD, genital herpes, warts, thrush,
obstetric trauma or mechanical injury causing painful scar, endometriosis, and post-radiotherapy. These can all other organic causes. In post-menopausal women, there is an estrogen deficiency leading to atrophic vaginitis, which can be a cause in the later life. Pudendal neuralgia, PID, pelvic organ prolapse, tumors, malignancy, comorbidities like chronic diseases, diabetes, multiple sclerosis, or spinal cord injury. They can lead to poor lubrication and insufficient vaginal expansion, and the result is vaginismus. These pelvic floor muscles are innervated by limbic system. So whenever there's an emotional change, it will also lead to vaginismus. Next. In vaginismus, there's a contraction of the outer third of the vagina, in which perivaginal muscles are involved, bulbocavernosus being the major one, along with levator ani and the pubococcygeus. Next. 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 Next slide, please. The grading was done by Lammert while doing a gynecological examination, in which grade 1 indicates a mild form of vaginismus where there's a spasm of levator ani muscle, and we just reassure the patient. Just simple counseling, the patient is able to relax, and we can do a gynecological examination. In grade 2, there's a spasm of levator ani muscles, and when we counsel or try to relax the patient, she is unable to relax, but we can do examination. Grade 3 is the severe form of vaginismus, in which patient avoids vaginal examination by elevating her buttocks. In grade 4, apart from elevating the buttocks, she retract and abduct the thighs, dorsal arching is done. And grade 5 was introduced by Passig, in which there is a visceral response to the examination. She wants to avoid at any cost. She tries to jump from the table, attacks the doctor, start shouting, shaking, crying, hyperventilating, and etc. Next. How the patient presents to us. It presents as a case of unconsummated marriage at a sexual dysfunction clinic, even in the infertility clinics. When we are asking about the history, we find that the patient is having non-consummation of marriage because of vaginismus, or while we are doing a gynec examination for some other complaints. Next. How does it affect? It affects the personal relation of the patient and partner, causing many of the anxiety disorders, dyspareunia, divorce, and even in the male, there's a development of sexual dysfunction like erectile dysfunction and premature ejaculation. Next. Next. Next slide. How we can diagnose it? Diagnosis is not difficult when we take careful history, and if patient allows the examination, only then we should do it. We should give sufficient time to the patient. So she should be comfortable with us. There should be privacy, confidentiality, and we should be non-judgmental. Next slide. We should always acknowledge the patient, listen to her, and observe her. Our body language should be such that she should not feel we are avoiding her or we are not interested in her talk. We should express respect, empathy, and genuineness. We should be having a good communication skill, and we should observe for non-verbal data also. Next. Next. Next slide. While evaluating the history, first thing we have to ask about what concept and beliefs she has, what influences vaginismus, what are her expectations, and what are her phobia, why there's a fear of pain, pregnancy, or HIV or AIDS. What is her religion, or what is her family or cultural background, whether there's a feeling of sex is sinful, guilty, sexual activity, doing it is wrong, it is a punishment, what history is getting out of marriage. What is her sexual knowledge? Irrespective, patient is highly educated, she can have low sexual knowledge. She can have a post-traumatic sexual experience, and can be a history of sexual abuse or rape in earlier life. There can be a domestic and social reason. There can be a stress in the life. There can be a financial problem, previous marriage or divorce, or there can be history of sexual violence earlier. So whenever there is a history of sexual violence, patient is having fear of intercourse now, and she can have vaginismus. Next. What type of bonding she is having with her partner? Is the marriage against her wish? Is there any fear of rejection, humiliation, performance pressure? If the vaginismus is situational, we should always ask about what situations are going to lead to vaginismus, and then we can alleviate or modify them so that she can relieve. Many a times there's a history of intake of anaphrodisiac drugs which decrease sexual desire, and the patient is having vaginismus. Even musculoskeletal pain, spine or backache can lead to this problem. Next. While taking history, sexual history is very, very important. We should always give importance to her. We should ask about sexual orientation, her feeling. Is there consummation of marriage has occurred, or still it is non-consummation? What is the frequency, desire, initiation, erotic thoughts? What are her interests? Is there any performance pressure? If she gets proper lubrication while doing her sex, if she has the same or variable experience with other partners, what type of foreplay or activity she indulge, is she is into masturbation practice. So all these things we have to ask in detail, only then we can come to a conclusion. Next. We should evaluate about medical disorder, chronic diseases, along with the hormonal level. Gynecological examination should only be done when the patient is comfortable and allows us. We should first inspect the external genitalia, find out the pain triggering spot, if any, on the genitalia or the vestibule. It can be a vestibulodynia or vulvodynia. There can be a post-surgical or post-infective scar in the vagina, like episiotomy, Bartholin cystectomy, or any other surgery, leading to pain, which may result into vaginismus. Infective conditions or vaginal dryness, atrophy, lichen sclerosis, thrush, wart, cancer can also lead the problem. We should assess for the muscle tone. In the case of hypertonic pelvic floor, there can be vaginismus. Speculum or digital examination should only be done when the patient is comfortable and she is allowing us. There can be a secondary vaginismus, the causes being secondary to endometriosis, interstitial cystitis, PID, pelvic congestion syndrome, adherent and fixed ovaries, adenomyosis, endometriosis are the common one, or hypertonic pelvic floor muscles. So we have to check for them. Next slide. Even the psychological and psychiatric condition like depression, stress, anxiety, phobia, personality type like OCD, narcissistic, anger disorder, psychiatric condition can also lead to this problem. Next. Differential diagnoses include vestibulodynia, vulvodynia, and deep dyspareunia. And while doing a checkup and history taking, we should keep these things in mind. Next. When it comes to the treatment, we should always assure the patient treatment is possible. She should have a confidence that she should be cured of this problem. And when we are counseling, better to do a couple counseling, and if not, patient counseling is important. Sex education should be given. We should ask about using proper lubrication while doing the intercourse. Pelvic floor exercises should be done. Excuse me. Please mute yourself. Please mute yourself. Systemic vaginal desensitization using dilators, fingers, or special instruments can be done. In the pharmacotherapy, anxiolytics can be used, physical therapy with or without biofeedback, psychotherapy, hypnotherapy, cognitive behavioral therapy, Sinate focus therapy, and use of Botox, which has really revolutionized the treatment of vaginismus are there. Next. So when we are doing a desensitization using dilators, initially we can use the patient's own little finger to do the dilatation so that she will not fear pain of anything foreign coming into her body. When she feel comfortable with that, we can increase the finger from little to middle, ring to middle, then the husband's finger can be used. If we are using with the dilator, firstly, it should be done in GA with proper lubrication. And we just ask the patient to remove the dilator by herself so that she has a confidence that this much my vagina can dilate. Dilators are available in different sizes from 19 mm to 35 mm in plastic, silicone, or glass. And whenever she's using a dilator, it should be a serial dilatation with proper lubrication and proper aseptic condition, because it can lead to infection if not done properly. Different type of dilators are available on the internet, and patient should have her own dilator. Next. Next slide, please. Next. Next. So it is the dilatation should be done only in the less severe type of the cases. In more severe, it is of less importance. In pharmacotherapy, anxiolytic and antidepressant drugs can be used, but they are better to use as a conjoint therapy with other therapy. Next slide, please. When it comes to the sex counseling, we should improve their communication skill, dominate compromised libido, should allay their anxiety and depression. And it is usually helpful in less severe of the cases and as a conjoint therapy with desensitization or Botox therapy. Next. Sinate focus therapy, as we have already discussed, is the therapy of being touched or touching, in which the bonding of the couple is increased and the fear of something foreign entering in her body is decreased. So it can be used as alone therapy or with a therapy with other or Botox or desensitization therapy. Next slide, please. Psychotherapy, in which cognitive behavioral therapy is important, in which patient understand the thought and feeling that impress behavior and helps reclaim the fear of penetration and avoidance behavior. And when the patient performs intercourse under CBT, her fear is decreased and the avoidance behavior is also decreased. And it is used mainly in the less severe cases of vaginismus. So, and also the woman who has undergone sexual abuse later and their fear of intercourse is decreased, and we can help the patient to improve in vaginismus. Next. Next. In the hypnotherapy, verbal interaction is done and we find out what is the cause which is leading to vaginismus. If we can cure it, we should modify the things so that her fear is reduced. Next slide. So the most important and revolutionary treatment in vaginismus has come, which is helpful in severe cases of vaginismus. Botox is a heat-labile neurotoxin, and it is a most lethal substance. It is available in 8 forms from A to H, and type A is mainly used in the therapy. Next. It causes flaccid paralysis of the muscle. It lasts from 7 to 10 days, and its effect is lasting for 3 to 9 months. So if there is a paralysis of the muscle, it will be for a longer period of time. The toxic dose is very high, that is 40 units per kg body weight, and the therapeutic doses range from 20 to 200 units. So there's a very large safety margin in therapeutic and toxic doses, so we can easily use in the treatment of vaginismus. Contraindication being myasthenia gravis, Lambert-Eaton syndrome, like muscular disorders, allergy to albumin, pregnancy, and lactation. Next. So how to insert the botulinum into the body It is very important to learn, because if we do an improper installation, it can lead to incontinence of the urine or the anus. So that we can use Botox or Diprot, and we have to inject at 3 points into the puborectalis muscle. If we draw an imaginary line, the 2, 3, and 4 o'clock position, and here 5, 8, 9, and 10 o'clock position. We have to inject at the lateral walls using an insulin syringe, or we can just insert a Sims speculum, which will obstruct urinary and anal sphincter, so that we will not inject at that point. If we are going to inject near those, it will cause flaccid paralysis of the sphincter muscle, leading to incontinence. Usually the action lasts for 6 months, but after doing intercourse for 6 months, the patient fear is released, so it can give a lifelong problem, can be cured. Adverse effects are mainly anal and urinary incontinence. There can be vaginal dryness or the failure of procedure. Next slide, please. So PASIC give a multimodal program in which he used, along with the Botox therapy, the desensitization therapy. If both are done together, then the results are very good. Even the 97% of the patient can be cured. Next slide, please. The treatment of partner is also important, because in many cases, the male patient partner can have erectile dysfunction or the premature ejaculation, and the high success rate despite in the trial highlights the importance of a cooperative, non-judgmental partner in the process of treatment of vaginismus. Next. Whenever there's an organic cause for vaginismus, we should treat it, like vulvar vestibular syndrome, vaginitis, urethritis, and cystitis. Treatment of endometriosis can be done by hormonal therapy, pain killers, or the surgical intervention. Next slide. So in the last, I just want to say, vaginismus is a common sexual dysfunction which is noticed in the gynae or the sexual medicine clinic. And the actual prevalence is very high than what we see, because many of the patients, they don't come for our help. And it's really going to affect the woman's health, emotional, as well as couple relationship. So it is our duty to properly evaluate, diagnose the cause, rule out differential diagnosis, determine the severity of vaginismus. We have to help in formulating the best treatment, what is possible for that patient. Next slide, please. In addition to the conventional therapy, botulinum toxin therapy is the revolutionary one in the treatment of vaginismus from mild to severe cases, and the multimodal approach of combining different therapy gives the better result than the single therapy. And still we are researching for the most effective treatment for vaginismus, and that can prevent the chances of recurrence. Next slide, please. So whenever we have got a treatment, and if the patient comes to us and if we counsel her, their treatment are possible. So why she should suffer in silence when we have got treatment for everything? We should give her wings so that she can fly. Thank you very much for the patient listening and for the inconvenience because of my lack of knowledge about the IT sector.
No, ma'am, it's absolutely, it happens with everybody. So it's not at all your fault. And you have been in such a long program, and you have done, it's wonderfully. Thank you so much, ma'am. Yeah. Sir, Neeraj sir. Yes, sir.
Yeah, stop sharing.
Yeah, ma'am. Yes, sir. Already stopped here. Yeah. So, Sangeeta ma'am, Sangeeta Thakur ma'am, your input, please. Ma'am, you have to unmute yourself. Sangeeta ma'am. आपको unmute करना होगा, Sangeeta ma'am.
Dr. Shadra Sinha, Dr. Sangeeta, Dr. Sipra. Anybody can take. Yeah, give the
Yes, namaste and good evening to everyone. Madam, your talk was such in detail. We learned many new things, but there are a few questions, ma'am. Just tell us, do we use Botox nowadays? But it is very common.
we can use it. We have to find out what the patient needs practically. Is a simple counseling can do. If it's a mild form, we can just counsel her, make her relax, she can do it. If it is a severe form, we have to definitely give her treatment, because just with counseling or with some simple pelvic floor relaxation, she will not give the proper relief. So the Botox is a better result. If we just insert the 3 injection, it is hardly that toxic dose is very high. So it is very safe to give, and the results are better. And we can go for the desensitization therapy also. And we have to counsel the
Please
patient.
explain the
Treatments are available.
site of injection. Please explain the
And ma'am,
site of injection. Injection
the
site.
botulinum toxin. That is botulinum toxin. It is a neurotoxin, basically a neurotoxin, and it is called flaccid paralysis of the muscles. It is also used in the skin treatment also for the cosmetic one. They are using.
You have mentioned the point of injection. What are the points?
They are on the lateral wall. I just the practical is that you just insert a Sims speculum. It will obstruct the urethra and the anus, and the lateral wall is easily visible, and you just insect with the insulin syringe. 3 points on the lateral wall, so that the anus, both the sphincter can be protected. Or just draw a imaginary clock at the vulva. 12 o'clock it can be a urethra, and 6 o'clock is the anus. And you can inject from 2, 3 and 5 o'clock position, and here 8, 9 and 10 o'clock position. So that because the major problem is to cause if the flaccid paralysis of the sphincter muscle will occur, then we will have the patient is going to have a problem for a 3 to 6 months. Or that is very problematic to her.
Okay, understand. Thank you, ma'am. Very excellent.
10% cases.
Some unknown facts. You have taken to some unknown facts. Thank you, ma'am.
Okay.
Botox therapy is required only in 10% cases.
Excellent talk, madam. Excellent talk.
Thank you.
In 90% of cases, with the counseling and the systemic
Dilatation.
we can manage patient.
Use of dilators can help to certain extent.
Systemic desensitization.
But because many times patients also have fear of the dilatation also, so we can give both the therapies, option of both the therapies to her.
Do we have?
Madam, what is not available? Finger is the same like dilator. So they can use finger also.
You can use the patient finger or the husband finger, what I have told.
Do we have special dilators for this?
We have got special dilators. They are available on the internet and on the Amazon. We can have it, but the fingers of the patient, her own finger is better, because she will not feel there is some foreign thing it is in this. She will feel comfortable in dilating. Then the husband finger can be used. Later on, we can use the dilators.
The dilators used previously in DNC. Okay. Does it
No. They have separate dilators for the vagina. They are very different. So that patient can't use.
Other type of dilators.
Madam, what is the treatment of secondary vaginismus, madam? If the patient didn't have any surgical trauma or any surgery, then in that case, what should be the treatment?
We have to find out what is the cause. Is there because of endometriosis, adenomyosis, or there is infective, even with the episiotomy scar, patient can have problem.
Okay.
Or there can be a PID or pelvic inflammatory disease, or simple prolapse can cause a problem. So we have to first find out the cause, only then we can treat it.
When endometriosis can cause.
Endometriosis can definitely cause both dyspareunia and along with that vaginismus.
Ma'am, dilators are used with anesthesia or without anesthesia?
First you have to do with anesthesia. You should never try without anesthesia, because patient would never allow you to put in something inside her vagina.
Thank you, ma'am.
What is the minimum number of your dilator, madam, to be started?
19 to 35.
19 to 35. You can start with a smaller one, then you can gradually dilate, up to which you can dilate yourself. And you ask your patient to remove it by herself, so that she will have confidence that up to 20 number or 30 now 35 number, I can dilate my vagina. So later on, she can start with the smaller one, and gradually she can increase the size. And the proper lubrication and aseptic conditions are very, very important.
Madam, I just want to know what is the minimum number to be started?
19.
19.
1.9 centimeter. 1.9 centimeter.
And how to sterilize it, madam, the silicone dilator? How to sterilize it?
You can ask the patient to just does with the
Yeah, but,
betadine solution, she can
formulation.
crystallize. It should be used for one patient. We should ask the patient to have her own dilators. And with a
Yes.
simple betadine solution, she can clean it up.
How long
Okay.
she has to put it in the vagina?
Till
How long should we put it? For just for few minutes to seconds. It is not, there is no such particular guidelines about that, how much time she will take. But
Basically, we are
gradually she can
dilating.
put.
How much time she feel
Basically, we are not
comfortable?
dilating. We are basically removing the fear of the patient.
Yeah, actually, exactly.
Okay, so now let's propose vote of thanks or
Thank you very
anything
much,
left.
Yes, yes.
Yeah.
Okay.
Hi, ma'am.
So
Before that,
really we are
thank you so much.
privileged. Yeah.
Okay. Yeah, ma'am. Thank you so much, the chairpersons and the speaker, Monica ma'am. Sadhna ma'am is there. Sangeeta ma'am is there. And Shipra ma'am is there. Thank you so much chairing the session and making this so delightful and so fruitful. And it is a really good discussion. Thank you so much for the session. And now is the time to say vote of thanks. And for that we have our own very own Dr. Kavita Varnwal ma'am for vote of thanks.
Okay, thank you, Apurva. So I think we are already running late. So really we are privileged to have this important webinar on less touch subject this evening. So on the behalf of Bhagalpur Obstetrics and Gynecological Society, it gives me extreme pleasure to propose vote of thanks to our President, Dr. Rishikesh Pai sir, Secretary General, Dr. Madhuri Patel Madam, and entire Foxy team for providing this important Zoom platform. My heartfelt thanks to chief guest of today's webinar, Dr. Asha Bakshi Madam, Vice President West, and Dr. Alka Pandey Madam, Vice President East, for their gracious presence and blessings. I am thankful to all the guests, Dr. Kumudni Jha Madam, Dr. Sumansana Madam, Dr. Pratibha Rai Madam, who not only blessed us, but their gracious presence make this webinar very useful. It's my sincere gratitude to Chairperson Sexual Medicine Committee, Foxy, Dr. Neeraj Yadav, sir, brought this important subject in our clinical practice. I am thankful to all the speakers, Dr. Ruma Sukla Madam, who spoke well on female sexual interest and arousal disorders and its treatment in elaborate way. Dr. Padmani Prasad Madam, who spoke on female orgasm disorders and its types and various points. So really, we learned so many new things. Dr. Monica Gupta Madam, who spoke on vaginismus, its diagnosis and how to manage. I am thankful to Dr. Pratibha Singh from our own society, who spoke so well on sexuality in pregnancy. And now I am thankful to all the chairperson, Dr. Nivedita from Bokaro, Dr. Ranjana Jha from Katihar, Dr. Leena Nardi from our society, Dr. Sipra Singh from Katihar, Dr. Sangeeta Thakur from Saharsa, Dr. Sadhna Sinha from Muzaffarpur, Dr. Lata Gupta from Sitamarhi, Dr. Roma Yadadi from our own society. So they could make this time available and they could chair the session so well in brilliant way. Lastly, I'm thankful to all the participants from all the societies. I think at one time the number was so good, 44 or 45. Without their presence, this webinar has no meaning. So they could spare time for this sexual disorder webinar, which was less talk. And I think nobody knows much and nobody likes to treat except psychiatric doctors. So I'm thankful to all these participants who have made this webinar so successful. Lastly, I'm thankful to coordinators of this session, Dr. Madan sir and Dr. Apurva Datta, who conducted so well and could spare time for making this webinar so useful. I'm thankful to our president, Dr. Rekha Jha Madam, for her continuous support and guidance to me. And I'm also thankful to MQR people who help us to making this flyer. So lastly, I'm thankful to all the persons, speakers, especially who had brilliant ideas and who could make this webinar so useful and so successful. So lastly, I'm thankful to all of you. Apurva, Madan sir, and all the chairpersons, and good night.
And thank you,
Yeah.
Chairperson Dr. Lakshmi Pinde and Secretary Dr. Ashok Kumar for granting us one ISOG credit point for this committee.
Yeah, for giving us one ICOG credit fund. Yeah, really, we are thankful to ICOG also. Not only President and Secretary General, but we are thankful to ICOG also. Okay, thank you.
Neeraj sir,
So thank you.
Neeraj sir,
Yes.
how to become a sexual medicine expert?
You have
to be in his unit. You have to be in his team. Then
Committee in this committee.
Sexual medicine committee.
ICOG certificate course also. It will be
an ICOG certificate course. You do.
Yeah.
Duration?
And do the survey. And do the survey which he has put in the chat box. That you must do. That survey.
We have classes for cosmetic gynecology. So like that, I think Dr. Ranjana is expecting classes for the sexual medicine.
There are master classes on that.
I think Dr. Archana Jha is there. Archana Di, you want to say something? Had you listened? I am seeing her. Archana Di, are you there?
She is there.
Okay. So anybody wants to say anything or anybody wants to say interaction from the audience also?
Excuse me.
Sir,